Good morning, everybody. Thank you so much for being here this week for the DESSH Clinic and today for the DESSH Family Conference and Symposium. I really can't express my gratitude to all of you enough because it's a huge sacrifice to travel, especially with our little ones, to come to a place like this and have them meet with doctors and be poked and prodded when that might be something that they're so used to at home, and to come on a quote vacation to do that is very, very taxing. I understand, and I can't from the bottom of my heart thank you enough, because all of your sacrifices today and everything that the kids are doing for this is going to just help all of us in the long run advance treatments and find the answers that we really need for DeSanto-Chenaui syndrome. I want to say there are a lot of people that we have to thank here. But before I get to them, can we just all give ourselves a round of applause for being here? So first and foremost, we have to thank Washington University and the St. Louis Children's Hospital for hosting us today and for being so gracious. We had a wonderful study coordinator. We had wonderful team there, all of the doctors, the staff on the 11th floor who's always there, and a huge notice that all the doctors that were there today or over the past 2 days donated their time. There was no insurance paperwork gone through. There were no expenses incurred by you or by the foundation for those doctors and the time that they spent collecting our data and helping us. So that's a huge win for everybody. Whoops. Along with that, we did have some exciting fun. Yeah. Okay. We'll get on it. So I also want to thank the all of the events and social outings that we were able to put together for this event. Of course, our homegrown local St. Louis family, the Smiths, Emily Carter and Susan Ford, who sits on our board as well, helped collect a great group of meals and outings for all of us today. And I wanted to just list that we had our welcome dinner from Hacienda. We had our lunch at the hospital from Antonino's, Panera Bread each morning. Last night was the Shack. Today we have Vitality Ballet. We had duo dogs at the conference clinic. Babalu is a performer who's probably up there right now entertaining our kids. The Missouri Botanical Garden, the 2 hotels that we used, Aloft and Doubletree, this space, of course, Epnic, and the photographer, Chase Parr. So here's a few items as we get started for today. After every presentation, there will be time for questions. We're going to stick to a strict-ish schedule. Some things will be moved around last minute, and we'll just go with the flow with that, but you will have time for questions. I will do my best to monitor the Zoom. That'll be a new feature this year. Last year, we couldn't take questions from Zoom, so I might be shouting out some of those as well. We have mics, so if you do have a question, raise your hand, and if we need it, I'll bring it up to you. There's going to be a 15-minute break at 10:30 for a quick refresh. And if you want to check on kids at that time, that's great. There's going to be snacks brought up to them at that time. But if they might still be hungry, feel free to grab things for them here. The presentations from today will all be made available online at deshclinic.com next week. And the recording and hopefully transcript of the conference will be shared as soon as it becomes available. At this time, is there anything that I have forgotten to mention or questions that you all might have for me before we get started? Yes. Oh, thank you. That's very thoughtful. Thank you. Okay. Without further ado, I would like to introduce the man who needs no introduction, who we all know and love so well, Dr. Marwan Chenaui.
All right. Good morning, everyone. I'm really excited to be here. Thank you, Caitlin, for the introducing. This is really a major effort I have actually, I should start with the acknowledgements, but I left this to the end because there are many individuals and institutions that we need to acknowledge for this really huge accomplishment for the third year. Um, but the main focus in my talk gonna be kind of overview about the DESSH syndrome. What are the clinical manifestations? I'll share with you some of the statistics that we collected through the years, focusing on the first clinic that was in 2022. So let's start with the definition, how we define actually DESH syndrome. So first of all, this is what we call an ultra rare condition. And I'll talk about the prevalence a little bit in the next slide. But this is extremely rare condition, and this is what we call an ultra rare condition that we described first in 2015. And there are certain cardinal clinical features that almost every individual would have to some degree some of these findings. So first of all, these are the delayed milestones and variable intellectual disability. And the second item here, these are the behavioral abnormalities. I'll go over in more details about each item here. But just to give you the frame, how define this condition, decreased muscle tone, or what we call hypotonia in our terminology, and other neurological findings such as seizures and some abnormal MRI abnormalities. GI abnormalities, we'll discuss this in a little bit more details. This can go from feeding, difficulties to constipation, and eye abnormalities. We'll discuss this item in a little bit more details, and facial differences, right? And these actually just to illustrate the frequency of these findings. So this data from the first clinic, 15 individuals attended that clinic in 2022. And as you can appreciate here, the first three items are related to the milestones. We have the gross and the fine motor milestones, and after that, the speech delay. And the facial differences are found in 100% of the individuals in that cohort. The behavioral abnormalities were documented in 93%. Hypotonia in 93%, sleep, we'll focus also on sleep, abnormalities in 80%, three-quarter had gastrointestinal abnormalities, and two-thirds had some eye abnormalities, and brain MRI abnormalities and seizures were found in half of the individuals. So back to the prevalence, this is very common question, and I didn't think about that, but a few families asked me, so before 2015, we didn't have this condition, how it was created. There were no individuals actually with this condition, and the answer obviously is no. Definitely, this is since we have the humanity and the cultures, definitely we have individuals with DESH syndrome, but we didn't call them at the time DESH syndrome. Either they were labeled with autism or intellectual disability or learning disability, or sometimes even just behavioral difficulties, such as ADHD. What we did in 2015, after collecting the first cohort of patients, we defined that condition, and then it was called actually DESH syndrome. We'll talk about the naming and things like that. I have actually a slide about that. Since then, there are 45 individuals documented in the literature with this condition. In our cohort here at WashU, and I communicated with many of you. either through emails or collected the data through the clinic, aware of at least 100 individuals. And we have complete clinical findings about those individuals. So total, my estimation, there are about 200, 250 that were tested and were proven to be affected with the DESSH syndrome. I'm very convinced there are many individuals who have not been tested and they have this condition. Whether this is really hundreds or thousands, it's hard to tell. But I'm very convinced, I mean, this is really way more common than I initially expected. Again, some additional data. Another question that I'm asked all the time, is there a difference between boys and girls? In general, the answer is no. It is equally affecting boys and girls. And the age of diagnosis, more and more actually, patients are being diagnosed during the first or the second year of life. They are referred either for evaluation of delayed milestones, speech delay, or even some early autistic features. And because of the accessibility to whole genome sequencing and whole exome sequencing, it's very easy actually to establish the diagnosis during the first year of life. And based on our data, the diagnosis was made using this whole genome or whole exome sequencing in the majority of cases. Other individuals are being diagnosed using what we call panels. So many times the insurance wouldn't approve the whole exome sequencing because of cost, expenses. And instead, we order what we call intellectual disability panel or autism panel. And usually the WAC gene, the gene causing DESSH syndrome, is usually included in these panels. And a minority of cases are diagnosed through the chromosomal microarray if those individuals have a deletion on a chromosome 10. We'll talk about this in a little bit more details. Out of the 12 individuals from the first clinic, if you remember, I mentioned we had 15. So 12 of them had parental testing. Their mom and dad were tested, and the 11 actually had what we call a brand new change, or what we call de novo mutation. They did not inherit the mutation from either their mom or dad. And only one individual had a maternally inherited variant. And we'll have more time actually to talk about the inheritance. So let's talk about the natural history, how we describe DESSH syndrome. So in early infancy and even the newborn, I hear again and again from many families that their child was a little bit more colicky. They cried all the time. And these are kind of non-specific findings, such as sometimes they would have acid reflux, which is very common actually in early infancy. Later on, maybe they exhibit some constipation. And after that, the physician would notice decreased muscle tone, hypotonia. Occasionally, the initial diagnosis is made through the ophthalmologist, who would notice some crossing eyes, or what we call strabismus, and they are referred for surgical correction, or other vision abnormalities. We did notice that during the first at least 3 years of life, there is recurrent infections. This can be just, runny nose or stuffy nose, but also lung infections, ear infections are very common. This can be associated with immune deficiency, and we are trying to study that element as well. A few cases have also short stature. It's very difficult to gain weight and length during the first few years of life. And I'm aware of a few individuals who were diagnosed with the growth hormone deficiency, and they are receiving treatment for that. When they get older, the most predominant features are related to the delayed milestones, to the learning disability, to the intellectual disability. But first of all, during the first 2 years, many parents would notice that their child is not really walking until the age of 20 months or even 30 months. They describe also fine motor skill abnormalities. It's difficult for them to hold the fork, the spoon. But the language acquisition, this is the most affected domain and almost universally found in all patients with DESSH syndrome. They start saying single words such as mama, dada during the first maybe 20 months of age. But there is a lag after that until they form sentences somewhere between 3 to 5 years of age, or even can take longer. Potty training is an issue, and many individuals with this condition take them somewhere between 3 to 8 years to be potty trained. Let's focus on the cognitive abilities or disabilities in individuals with this condition. And this is something that we don't understand, why we have so broad variations among individuals. In my opinion, and I'm sharing this all the time with many families, regardless when the diagnosis is made, but definitely if it's made during the first 5 years of life, you can change the outcome there by the interventions that we're offering, including physical therapy, occupational therapy, speech interventions, and sometimes ABA if there are some autistic features. So this is definitely a contributing factor maybe for the variations. And we know different states and different countries would offer different possibilities of therapies, but I do believe that each one of you should fight. I'm ready actually to share some recommendation letters, why those kids are really so important really to provide intensive therapies. I usually mention this to family that we have this significant plasticity of the brain during the first 5 years, although there are data indicating this plasticity can last actually even to adulthood. But the main focus during the first 5 years, where definitely you can do all of these stimulation, teaching, and all of these can change the outcome. Usually, it's not really severe or a profound intellectual disability. It is mostly the mild range, but there are a few individuals who have moderate intellectual disability. And by the way, the criteria for making the diagnosis is they don't rely now on the IQ testing. They're talking now about their ability to participate in different daily life activities, whether they need observation and things like that. Based on the data that we collected in 2022, so the average was about the IQ average from those individuals who had IQ testing 66, and the range was between 50 to 80. But again, lots of variation. There are individuals who are falling in the normal range of cognitive abilities. Behavioral abnormalities. So I think Caitlin was communicating with many families trying to understand what is item number one that you would like really to fix or to find medication for. And I think this is the most significant part that definitely can be to some extent can be, it would be nice really to find medications or interventions to fix these things. It would be much easier for those kids and for their families. So again, the behavioral abnormalities can go from being a colicky baby during the first few months of life, but later on, we recognize ADHD as a significant component, aggressive behaviors toward the others or themselves, what we call the SIB. This is self-injurious behaviors. Impulsivity and stubbornness. And I'm sure that at least a few of you share these exact terms when they describe their kids. Autism or autistic features. Initially, we thought that every child would have autism, but this is not true. There are Only maybe 35% would meet the criteria for autism, but the additional 15% have some autistic features. Anxiety becoming a big component that I recognize more and more. OCD and the sleep abnormalities, either falling asleep or awakening during the night. There are some reports also of sleep apnea, breathing difficulties at night as well. And this is the prevalence of the behavioral abnormality. It was really surprising from our first clinic. It was surprising to see that the OCD actually was one item here. 2/3 of the individuals, ADHD, 60%, anxiety, about half, and aggression, self-injurious behaviors in about 50%, autism, autistic traits, 40%, and impulsivity in 13%. Let's talk about the neurological findings. So every year, actually, we had in a previous symposium, we had a talk about the neurological findings. Unfortunately, they couldn't make it this year. So I am illustrating here the main neurological findings. So in addition to the delayed milestones, hypotonia, especially during the first 1 or 2 years of life, this is a contributing factor for the delayed motor skills. And later on, you notice that there are a few kids exhibiting some drooling. This can be related to the decreased muscle tone in the facial area. This is not because of overproduction of saliva. Seizures, with the initial cohort, we had 47% of patients having seizures. But I think this is really overestimation. I think there was a bias. Those individuals who had seizure, maybe there was a bias. They wanted really to see more physicians. They came more to the clinic. Based on a whole cohort of about, and I calculated this for the 150 individuals that are known at this time, it's about 25%. Usually these can be tonic-clonic seizures or absence seizures or even febrile seizures. There is something unique with the sleep. So sometimes these seizures are triggered during sleep, or you can detect them only if you do 24-hour EEG. Many times, it's well known that you can have clinical seizures, but the EEG would be completely normal. Things to watch from your standpoint, definitely unusual body movements, some staring episodes and things like that. Share with your primary care physician who can communicate with the geneticist, or obviously with the neurologist would be the first to communicate with. Brain imaging may reveal some abnormality. This can go from what we call ventriculomegaly, enlarged ventricles. These are the empty spaces inside the brain, or corpus callosum abnormalities. So this is the structure connecting the two hemispheres. Actually, this was a trigger from our scientist, Daniel. He asked me what brain MRI abnormalities you found in your cohort, and I didn't pay attention to the corpus callosum. So it started from an animal model, some observations that led actually me to go and search the data for these abnormalities, just illustrating the interaction and the exchange of data between our research team and the clinical team, and vice versa. Actually, we share with scientists lots of information that can be beneficial for them to use or to look for in the animal models. There is some indication that patients with epilepsy have higher chance to have a brain MRI abnormalities. Many, but not all individuals with DESSH syndrome exhibit recognizable facial features. And I should spend a few minutes about this issue. So first of all, this can be a sensitive issue to discuss. So this is one thing. Usually I use the terminology of facial differences. This is less offensive than, dysmorphic features. Because with dysmorphic features, sometimes this can indicate some dysmorphia, some abnormalities in the face, but honestly, most of these are really more cosmetic issues. They are good for the clinician to recognize that condition and order the genetic testing for that. But they don't have really any functional significance. So if we describe deep set eyes, I mean, this has nothing to do with the function of the eye. It would be more important for me really to recognize, cortical visual impairment, for instance. This is more important than just, the deep set eyes and things like that. Nevertheless, I listed here how we recognize the facial features. So there is in our field in genetics, we have, and the training for to be a geneticist is kind of a little bit difficult because we need to learn about, 6 to 7,000 different conditions that are labeled with genetic syndromes. I know that long time ago we had Down syndrome, we had Turner syndrome, but the data exploded over time that it would be impossible for an average geneticist to recognize all of these genetic conditions. So to be an expert in any condition, you need to see at least, 30, 40 individuals with the same condition. So you build a pattern in your brain. So the next time you see individual with that condition, somehow your brain would trigger the thought about that. This is the way our brain is working. So I don't blame anyone if they didn't recognize these features, I mean, or the delay. I do believe that we should have definitely access to genetic testing. Some of these findings are really non-specific. Delayed milestones can be everything. But my argument, I'm not asking to recognize the spatial feature, but to offer genetic testing as early as you can. Why I'm emphasizing that? To do the interventions early on. This is really so important. Right, so these are you recognize some of maybe your kids here. What is the most characteristic? Usually we're talking about deep set eyes, the thick eyebrows, if you noticed, what we call the squared face. So you would ask how we learn these things. So this is part actually of our teaching, how we teach our trainees to recognize. Sometimes there are certain measurements to do. For instance, if they have large head size, what we call macrocephaly. So we need to do measurement, or how we define, for instance, large ears. So we need to do actual measurements. But honestly, for most of these that I listed in the previous slide, these are more subjective. This is just by observation. I know there is no measurement to determine whether this is really deep set eyes or not, or there is no measurement to say that this is really thick eyebrow or not. But these are some of the findings. Hirsutism, this is excessive hair, most likely you noticed, and the kids here with excessive hair, sometimes there is what we call unibrow. This is the fusion between the two eyebrows. This is also, I consider this as very characteristic. So these are the two siblings that I initially have seen here. And this is actually what started the discovery of this condition. So they came to me initially for evaluation of learning disability, ADHD, and some other behavioral abnormality. And we did the exome sequencing and we received the results of the WAC gene, which I was surprised what exactly this gene. And we started communicating with other physicians around the world. And this is the way we actually describe the first cohort. Some other features that initially we didn't realize, but they are common, the dental anomalies. So we need to watch this over time. Lots of cavities, and many kids actually I noticed on physical exam, they had capping of their teeth or molars, but also the orientation or the shape or the position of the teeth. And sometimes they have large incisors. So this is one characteristic. more and more we recognize the feet anomalies. This is a progressive. Honestly, this is the only finding that I would remember now that would not appear at birth, and over time we see it. So we need to watch these feet. Usually I refer them to orthopedics against the surgical interventions, because in a few cases, the outcome wasn't really great. You can see, for instance, also fusion between the toe number 2 and 3 here. This is, we call this syndactyly, or overlapping of toes. You can see the excessive hair in this specific case as well. Other findings, the thick and the broad eyebrows. This is really very characteristic. Sometimes you see a faint fusion between the two eyebrows here and hirsutism on the back. Sometimes there can be also ear anomalies, either pits or creases. And we collected actually the statistics to try to understand what is the most recognizable facial differences in those individuals. In my opinion, the eyes are really the most characteristic. If I see the eyes with the square face, this is really very characteristic. And what I'm referring to the eye, this would include the deep set eyes, as well as the thick eyebrows and the fusion between the two eyebrows. I did mention here hirsutism also is very, very common, and the other things that we mentioned there. So the next is really if we go to the nose, the abnormalities are found in about 50%. This can be depressed nasal bridge, or short, what we describe as short nose. The mouth abnormalities, sometimes the wide mouth can be very characteristic. And when we do the oral exam, we see dental anomaly that I just described. Only in 1/3 of the patient, there are some ear anomalies. So I wouldn't consider the ears as very diagnostic. So what's the etiology of DESSH syndrome? It is caused by mutations or genetic variants in a gene that is called a WW domain containing adapter coiled coil. It's a very long name, but much easier to say just WAC. So it's describing actually different domains in the protein, the coil, and the WW domain. So these are a critical domain in the protein itself. And just you can say just the WAC or the WAC. The WAC would have a little bit different connotation, but WAC should be fine. So the great majority of patients actually have what we call point mutation, very small change in the gene itself. And when you receive the report of the exome or the whole genome sequencing, you can see either mutation, they mention actually mutations, or more and more we talk about pathogenic variants. So we have many variants in our genome, but pathogenic, it means they are causing a disease. And all of these mutations are really very disruptive for the function of the gene and the protein. But the good news, and I mentioned this for many of you, these are what we call amenable for genetic interventions, or these can be splice site mutations, nonsense mutations, and these very easy to handle in the lab to do the gene therapy. You can create a small segment of the oligonucleotide. They call this technology now the ASO, and you can block actually the abnormal splicing of the gene or the messenger RNA. So most of these, which is good, I know that there are severe mutations, they're disruptive for the function, but they are amenable to these genetic interventions. There are a few individuals who are having a deletion, is a missing piece on the short arm of chromosome 10. Why we're emphasizing that? Because this is the location of the WAC gene on the short arm of a chromosome 10. And I have a slide actually about these deletions. There was a debate initially whether we should call those individuals as having DESSH syndrome. In my opinion, yes. because most of the characteristics, including delayed milestones, even the facial differences that were described in the literature, are overlapping with the DESSH syndrome because of point mutations. So the conclusion that a lack of one copy of the WAC gene is responsible for most of the clinical feature, despite the fact that in that deletion, there can be many other genes that are deleted. But the most prominent and the most significant of those genes is really the WAC gene. Genotype-phenotype correlation, this is really a very important point. Many of you asked me why we have these variations. We interacted with other families. Why we have these variations among individuals with DESSH syndrome. So the short answer, we don't know, but we have different hypotheses. So one of them is maybe the type of the mutation is really contributing to that. If you have this mutation in that location of the gene, you would have less severe manifestations or more severe, it depends. And initially what we thought that those individuals with the C-terminal mutation, the last half of the protein would have mildly affected. And this is what we wrote in our initial article. I don't think it's really valid when I evaluated the whole cohort. And we are still trying to understand maybe the type of the mutation, splicing versus nonsense or missense mutations. So all of these are really important factors. The position of the mutation also may affect different isoforms. So when we talk about isoforms, these are different forms of the protein. So looks like based on research studies, this is not a single protein that we call the WAC. There are different forms of that protein. And this is illustrated here. So I listed here three different forms of the same protein. So this is the one that is complete without any missing pieces from that protein. It contains 647 amino acids, but there are two isoforms. And interestingly, one of them actually is expressed in the brain with missing the first 45 amino acids. So if your child has mutation in that location, it's not going to affect that protein, that form of the protein, which definitely can explain some of these variations. By searching last night, I noticed there are more than 20 isoforms for the WAC gene, but only 9 or 10 of them have can produce actual protein there. The others are none, we don't consider them as functional. And this is the location of the mutation. They are distributed everywhere in the gene. All right. Most cases, as I mentioned before, of DESSH syndrome are not inherited. Mom and dad are negative. When we do the testing for them are negative, and this is the terminology that we use. This is de novo mutations. So you would ask, so how come we call this genetic? So genetic, referring that this is a genetic change. It's different from inherited. So genetic can be genetic, but not inherited. Right, so sometimes there can be a confusion there. So when actually these mutations occurred, they occur during the production either of the sperms or the eggs. It's hard to tell because we didn't do a study to there are certain methods that we can determine that, but I don't think we have this information. All the cases where, but nevertheless, there are 4 to 5 families who had recurrence of the DESSH syndrome in the second child. Oh, I have something in my computer signed out. I don't know why. It says signed out, the Zoom. Unable to sign into that. Yeah, we're connected. We're good. Okay. Okay, so maybe this is just, okay, very good. So the question here, how come that you can have recurrence on the second child? So the theory that the same parent would have the same exact mutation in another sperm. This is what we call germline mosaicism. Usually we test you in blood or saliva or buccal swabs, but we don't go and check germ cells. So this is the reason usually when I counsel families for recurrence, I don't say 0% because there is a chance if you have a child with DESSH syndrome to have another child with DESSH syndrome. Usually my estimation 2 to 3%. So the big issue, I don't know why I say it. I can manage here. Recent data suggests that there are families who actually the parent is affected, indicating that the mutation is not really severely. Actually, I follow a 3-generation family, a grandmother, mother, and 2 kids with DESH syndrome, and they are from Illinois. And the mutation, surprisingly, is found in the first part that I mentioned to you at amino acid number 9. They are not severely affected. The fact that they had social relationship, the mother and the grandmother had formed families, indicating that they were not really severely affected. And there are a few cases like that. For all cases with the deletions, these are not inherited. I never encountered any case with the deletion with inherited from the parent, but nevertheless, we usually recommend to test mom and dad because they may have some rearrangements in their chromosomes that would increase, or we call these balanced translocations. That may increase the risk of having a child with DESH. So what is the naming? You would hear different stories about how they named actually DESH as DESH syndrome. Why not intellectual disability? So intellectual disability is just a general term. It doesn't describe any specific genetic condition. So OMM, this is the online inheritance in man, usually do the naming of these cases, of these newly discovered genetic syndromes. And this is kind of collection of genetic data as well as phenotypic data. And so they decided actually to give the name for, so DeSanto, this was a medical student who worked with me at the time on describing that condition. She was doing rotations with genetics, and we together worked in that project, and this is the way we described that condition. You would argue why it's not really called the WAC-related disorder, which definitely this is the trend now, to take the name of the gene and to say related disorder, take the name of the gene related disorder, WAC-related disorder. Sometimes I use that terminology, which is completely fine. But the potential limitation of this are the following. The same gene can cause different diseases. It's well known. There are genes that can cause 20 conditions. So you need to be more specific. It's less convenient for families to say that my child has WAC-related disorder. Nobody would understand what exactly it means. And the gene names and association can change over time. And in fact, this is the actual name of the gene. There is this is the OMM, and if you go to the omm.org, you would find this nomenclature, and they included the chromosome 10p deletion as part of this syndrome. I'll leave this to our researchers actually to discuss the function of the WAC gene, and I have 2-3 slides about what is next. So in my opinion, there can be different approaches here, how we can move to try to ultimately find a cure for this condition. So first of all, to study a larger cohort of patients, this is so essential. I mean, when you study 6 individuals with DESH syndrome, this wouldn't give you the spectrum of clinical manifestations. The larger the cohorts, to include even mildly affected cases, so important not to be biased by including more severely affected cases. So this is really very important to study individuals over time to see the natural history of that condition. And I see significant value of studying adult patients to see how they're doing at this time. instead of waiting 20 years until we get the natural history. So why not to focus on adult patients who already, went through different stages in their life and to see what are the clinical manifestations. This can be tricky because they can have adults onset conditions. One of those individuals actually have DASH syndrome about, I think maybe in their 50s, and Parkinson disease. Can we say that all individuals, when they get to the age of 50, will have Parkinson disease? It's hard to tell. To make association, you need recurrence of the same symptom. And they study the effect of early therapeutic intervention, PT/OT, on the outcome, but also medical interventions, such as for ADHD and other interventions, and the gene therapy. So this is just to illustrate for you some of the data that we collected and how large cohort actually can give us additional information. So we collected just what medications those kids are taking. And two-thirds actually of patients with DASH syndrome are taking some kind of medication. One-third are taking for constipation, which is very obvious. It's very common manifestation. But I was surprised, and I didn't realize that one-third of them are taking allergy medications, which is very important. So after receiving this kind of data, I went back and started asking families, does your child have any allergies, seasonal allergies? So this is just really to illustrate for you how we can go from large data and start asking specific question based on this large data. And there was no intention actually to study allergy or immunology in those individuals. And the other findings we already discussed in epilepsy and things like that. Another thing to illustrate here, so this is usually the normal distribution of our weight. In fact, this is more in the United States. There are 30 or more than 35% of overweight in the United States. So there is a left shift in the weight right here. But this is what, when we did actually the data for our large cohort, look at that, significant skewing. And many of you actually asked these questions when they slightly get older to late childhood, definitely they would see a little bit more gaining weight. This becomes more obvious actually if you, because the BMI, this is the ratio between the weight and the height. So those kids are, and individuals with the syndrome are shorter. So when you calculate the ratio between the weight, and this obviously would require our attention because this would increase the risk of having diabetes, of hyperlipidemia and heart disease. So these are really very important to consider. And this is just from the statistic, just because of limitation in time. And and definitely our researchers, and I'm so excited and waiting to hear about the update since last year. This effort gonna lead ultimately to start thinking about some interventions, either gene therapy or other interventions. So we have a zebrafish model, the mouse model at this time, but there is a value of studying in vitro in the lab the cells that we got from the skin biopsies. And they're going to discuss, our researchers here at WashU, how they can convert these into neurons and things like that in the lab and study the effect of these. And obviously the long-term goal, and this is the way we initiated actually this foundation, Caitlin definitely leading the effort for that, really to try to find a cure for this condition. And again, this effort is really illustrating how important the collaboration between clinicians, between academic institutions and family support group. And again, this is not just, I'm saying this because all of you are involved in that effort. This is real. With the huge number of discoveries that we're having, we need families actually to lead this effort, to stimulate researchers. And this, in fact, that is what we experience over the years. Caitlin was very persistent, and other members of the DESSH Foundation about, let's talk with this researcher, let's contact that clinician. This is the way that definitely we are proud of this effort. And obviously the future of the DESSH Foundation is really very important. This is the third year that we're holding that. The value that I see that at least half of the individuals I've seen in previous clinics. So we see the evolution over time. When we go and apply for FDA approval, they ask about, natural history data. And definitely this would have lots of value to submit to the FDA for any approval of medications in the future. One thing, just the last minute, I'm finishing, Caitlin. So with the professionals, so as I told you, we are acquiring as a professionals here at WashU the expertise that is needed to see, to evaluate correctly, to give correct recommendations and guidelines for families. So this is really very important, and the collection of the samples is also very important. All right, so last slide, the acknowledgements, many to acknowledge here, but definitely I would start with the DESSH Foundation. Caitlin and Susan had many meetings to work on the clinic, the schedule, who's going to be there, what time each patient, who's going to see neurology, genetics, and psychology, and ophthalmology. So all of these are really very important. Patients and their families, I know what major effort you made to travel here, and even Germany, Puerto Rico, and other countries. So definitely this is so exciting. So we are really proud of you that you're making this effort. I know that we are volunteering for that, which is really an advantage, but we know that we appreciate all the effort that you're making to come here, because all of you, this is what I hear all the time, your contribution to science is so important, and you are willing actually to contribute to science to ultimately find a treatment for this condition. And the Division of Genetics and Genomic Medicine, Dr. Patty Dixon, the chair of our division, full support all the time. Pediatric neurology, Dr. Weisenberg, she's not able to be here, correct, Caitlin? And ophthalmology, Dr. Reynolds, and the psychology service, and the IDDRC, and obviously the PCRU, where actually we hold the clinic. All right, thank you. So we need a question to the end? Or?
No, we could do questions now.
Okay.
Yeah, if that
Sounds
works for
good.
you.
Easy
I'm gonna
question,
run them
please.
around. Skyla has a question, but you have to ask in the mic so that the Zoom group can hear.
Thank you again for your time and all of the research you've done to bring us all together and help us get answers for our families. I have a son that's 14. You mentioned an adult patient with DESSH, and I wondered if there were any similar data sets or concerns in adult patients that you're aware of beyond the issues identified in pediatric patients?
Yes, so let me go here. It is my impression that the behavioral components are getting a little bit, I don't know if these are really the medical interventions, accessibility to psychology, psychiatry, but most of adult patients are really, their behavioral challenges are well controlled. But there are other issues that we're watching over time. So one of the things that I mentioned, diabetes, it looks like this is higher prevalence that we need to watch over time. Overweight with its complications such as sleep abnormalities at night and things like that. So this is really important. It is not clear to me whether there is, we don't consider this condition as a neurodegenerative condition. We don't expect significant decline over time. I did mention the Parkinson, but I'm not really very convinced at this point that the association is very tight with the DESSH in that I know this patient is being studied in Mayo Clinic, and they are trying to find the connection between the mutation in the WAC and the Parkinson disease. So it's hard to tell at this point. But these are the changes. We don't have enough adults actually to give you correct answers, statistics and things like that. But these are really the general observations.
Hi, we have a question from, is it an email question? WhatsApp group question. People were wondering if you've noticed a behavioral difference between male and females as they age.
It's a very good question, and this is what we are trying to do the analysis. We didn't finish the analysis. It is not, I mean, it's not really very obvious at this point. It's just a general impression. There are no significant differences. And female boys and girls can be equally affected, including behavioral abnormalities. But I'll get the data soon. This is what we are hoping, yeah, to everyone.
Hi, you
Hi.
said something about the 10p deletions and
Correct.
congenital heart defects was listed.
Okay,
Do you have?
sorry. Yes. I forgot to mention that. Thank you for mentioning that. If you go and read about this condition, actually, there is a few reports of association between congenital heart defects and DESSH syndrome. In my large cohort of patients, more than 100 individuals, there are only a few patients who had some abnormalities, and these are not severe. This can go from a hole between the two ventricles, what we call VSD or ASD. This is a hole between the two atria, or PFO. So these can be normal during early stages of life. But no major, I'm aware of a few publications that mention the congenital heart defects, even in patients with the point mutations. There is the notion that if the deletion is bigger than that would include many other genes other than the WAC gene, there can be higher chance of having congenital heart defects. Thank you for asking that. And I usually don't recommend automatically to do an echo, to do physical exam. And if there is a murmur, if there are any cardiac related symptoms, then to do the echo. But this is not routine recommendation to screen with the echo. It's nice to do it, but again, it's not really a recommendation.
Hi, thank you. We were wondering if there's any prognosis of, first of all, medication for the future to prevent DESSH or other testing. And my second question is,
You're asking about medications or other interventions, or
if medication could prevent the DESSH syndrome.
Mhm.
And second question would be if there are cases of adult or young adult patients who can live their life like independently.
Yeah, thank you. Thank you so much. So let's focus on the first question regarding how we can prevent. So it's a big term. So the only way we can prevent that, obviously, if you do prenatal testing, and there are different regulations in different states and different countries. But the only scenario that I see, if you have one child with DESSH syndrome and you want really to do prenatal testing for the next pregnancy, to avoid this small risk of 2 to 3% chance of recurrence. But usually we don't think about, the syndrome prenatally. There are no certain signs that can predict that. And I'm not aware if the question also relevant to medication that can prevent some late, outcomes. It's very, no, we don't have such medications. I do believe that early interventions definitely would make the outcome, cognitive and behavioral outcome, much better if you do the interventions, including physical, occupational, and speech therapy or ABA. And the second question regarding adults, I think we discussed this issue before. Yes, there are adult patients with this condition. I did mention the 3-generation family and the grandmother. Actually, I'm seeing her every other year. And she's doing just fine. I think she's just a little bit overweight, diabetes, and things like that. There are no other neurological symptoms, and there are no decline, significant decline over time.
I think the second question was, are there any adults that are known to live independently?
Independent. Okay, thank you. So yes, there are, and usually, for instance, the family that I mentioned there, but many patients would require assisted living, and there can be different arrangements based on where you live and what kind of community you want your child to be, or your son or daughter to be. So there can be, and this is really very good question. It's very difficult to predict. If we get to the point that any child affected with this condition would have some degree of independency in the future, to have, some assisted living or community living and things like that with minimal assistance, that would be great for the majority of patients. There are, I mentioned to you, there are individuals who are having normal IQ testing, and those I would predict to have, they would have jobs, they would have integrate into the society, and they would form families and things like that. I do believe that there is a bias of those individuals who are being diagnosed, because we do the testing usually for individuals who are more severely affected. I do believe that if we do testing, general testing for almost everyone, we will detect those very mild cases who actually already formed families. And so there is a bias with the data that we have at this time.
Wait, do it into the microphone.
Just to ask the question, you had mentioned earlier about what was it, gene therapy, and how it impacts or could in the future impact individuals with point mutations on the WAC gene. What are sort of the next steps to kind of get us to that endpoint, and
Excellent.
how do we assist?
So this is a long road, and definitely we started this process, with the effort that we're making here, including locally, but also many other researchers who are involved in this effort. And this is the reason that we did the collection of the fibroblasts and things like that. So specifically, we can test how we can avoid, block the effect of the mutation in vitro. So this is really in the lab. It's feasible to do it. I don't see any difficulties in doing that. And the tools are there. But from there to translate this into, a clinical trial, the road is really very long. So you need to make sure the safety, the correct machinery, what is the vehicle that can transfer that gene, and the target. You need to target the brain. Not only the brain, specific areas in the brain, right? We need to understand what exactly the highest expression of the gene, where it's located. So all of these are really big considerations. And another consideration, when to start the treatment. Is it okay? Actually, let's assume that everything you have exactly the vector, you have the gene to inject, and you decide to do injection into the brain. But the question, when to do that? Is it okay to do the treatment at 15 years of age? Or this has to be in the first year of life or the first month of life? So all of these, and this is not only for this condition, for all neuro developmental disorder, and this is one of them. This is the same question that we're facing all the time. The technology is there. There are obstacles about, limitations, side effects of this kind of treatment and things like that. Rule number one in medicine, do not cause harm, right? We don't really want to get to the point that we're causing harm there. So, and But the data that we are really collecting here is so important, because if you find that treatment, you need measurement, how you decide that this is really very effective treatment. And more than that, we need to collect biomarkers, biological biomarkers, how to measure the efficacy of that treatment. So the road is long, but I think we started this process.
I have a couple of Zoom questions, and then I do want to move on to our next presenter. But Dr. Shinawi, will you be here the remaining for the whole conference this morning?
Yeah.
Oh, wonderful. So if there's anyone else in the room that needs has a question, we can ask Dr. Shinawi then. So one question I have online is, do you know any patients that have not developed language ever as they grow? There
are a few patients who nonverbal.
Who are nonverbal as older than adults, teens?
Adults, I'm not sure, but I'm aware of kids, a few kids who are nonverbal. Yep.
Okay. And so we don't know if they'll develop language later?
Say it again.
Is it possible they would develop language at a later time?
It's hard to tell. In early life, I mean, usually I tell family, don't give up. So important to continue with the therapies and things like that, intervention, speech therapy. So these are really important, especially if we're talking about apraxia or other kinds of speech delays. And I'm aware of a few patients who were nonverbal until the age of 3 years of age. And suddenly after that, they acquired really very good vocabulary and language. Later in life, it's hard to tell, honestly. My prediction would be no, would be difficult, just because what I mentioned, plasticity of the brain maybe, or other factors.
Thanks. And is there any data being collected based on those who have started with early interventions versus those who haven't, and what behavior is like as they get older?
Excellent question. I wish we have this information, but we don't. I wish we can do this study. Obviously, it's non-ethical to take two groups, control group without intervention and those with intervention. But retrospective study, you can evaluate those who received and not receive. We did ask actually all patients this question, and we can do the analysis.
We'll add it to the natural history study.
Exactly.
Okay. Thank you so much, Dr. Shinawi.
Thank you.
Hello, everyone. My name is Dr. Karine American, and I'm a pediatric gastroenterologist here at WashU. Oops. And I am very happy to be here today to talk to you about constipation. So my objectives are to kind of talk about what is constipation, what are the causes generally, and how patients who have DESSH syndrome, how some of their specific issues might relate to constipation and the development of constipation. And then some of the typical remedies and also treatments for constipation. So causes of constipation, there are very many. Most of the time, sometimes it's idiopathic, we don't know, but very commonly it can be related to not drinking enough fluids, not getting enough water in, not eating enough fiber. Constipation can often become apparent when children start to do potty training, and that can be associated with a lot of issues like being worried about going to poop on the big toilet. They've never done that before. That's scary. They are very anxious about it. And so what happens is that they don't want to go poop, or they're playing and they don't want to interrupt their playtime. And so they basically start to hold it in. And that starts a big cycle of the poop is stuck inside. It's really, like, as time goes on, it's more and more painful for it to come out. And when it does come out, it causes them pain. And so then they're worried even more about it for next time. So that can be a difficult cycle to break. Some medications can have side effects of constipation. Um, and then there could be, of course, anatomical things like strictures within the intestines or narrowing, some anatomical things like anteriorly displaced anus or anal malformations, and also Hirschsprung's disease, which is a disease that occurs when the neurons in utero do not migrate to the right place in the rectum, and then the rectum is not innervated the right way. So then there is a problem with the feedback mechanism. And so basically poop is stuck inside and kids cannot let it come out. It won't come out. Other things that can contribute to constipation include hypotonia. So if you have a low tone and, you know, it makes it more difficult to push the poop out. And then also metabolic conditions, electrolyte abnormalities can also contribute to that, as well as various neurologic conditions like spina bifida and other neurologic problems too. So specifically in DESSH, I think the things that mainly are likely contributing to the development of constipation is hypotonia for sure, likely diet, and with some behavior problems as well, such as aggression, anxiety, ADHD, features of autism. Sometimes behavior can really affect what the child eats, and maybe they're a very picky eater and they are only able to eat these certain type of chicken nuggets and crackers, and that's it. And it's really hard to get any other kind of fruit or vegetables in. So that definitely contributes to constipation. Not, as I mentioned before, not drinking enough water, fluid, things like that. And then if the children take any medications for behavior like ADHD, some of those have some side effects of constipation as well. So it's kind of a lot of things really contributing to constipation. So it's very clear, it's likely to be a big problem for these kids. And then in addition to behavior, if like not wanting to go poop and holding it in, that is all perpetuated. So one of the things I wanted to talk about regarding like the anatomical problems, just to kind of explain what can happen when kids really hold the poop in and they don't poop, and constipation really becomes a big problem. What happens is usually they get a redundant colon. And this is a contrast study. So this is a contrast enema. Basically an enema with contrast, and then they took an x-ray. And so here, all that big white space is the rectum and the sigmoid colon, and you can see how dilated it is. So what happens is the longer the poop stays inside the rectum and the sigmoid and goes all the way up, it's basically more poop gets added in, and it causes the colon to stretch out and the rectum to stretch out. And then that now becomes a much bigger space that is able to hold in more poop. So, and there is basically the signal that when you eat, it's called the gastrocolic reflex. When you eat, it sends a signal to your rectum and colon that it's time to use the bathroom. And in young kids age 3 to 4, this is just starting to develop. And this is the time when they're doing potty training. So this can all get a little bit thrown off balance during this time. And especially if you couple this with this, that kids are holding it in and that rectum is becoming more capacious, that means those kids need to get much more poop in them in that area. They need much more poop in that area in order for that stimulus that I need to go use the bathroom to be sent. And so eventually what can happen over time is that you can collect so much poop in this distal part of the rectum that eventually then it starts leaking around the edges. And so that's when you start seeing smears and liquid poop coming out. So, and at that point it can become very confusing because you think that it's actually liquid poop and diarrhea coming out, but in fact, it means you are actually really, really constipated. So it's a big, big issue, and it's a big quality of life issue for both the children and the parents and all the families. It can be difficult to take care of, and that's why it's so important to, get started on working on this problem right away, and making sure that kids do have a good size, big, soft bowel movement every day without any pain and without any blood. That's the goal we want to see. And then another thing I wanted to mention, and this is really kind of when it's really, really severe, like past the stage when this kind of stage has been going on for many years, what can happen is that the colon is really stretched and dilated. And even when it's clear of all the poop, because it's so stretched out, there is a risk for volvulus, which means a twisting of the intestines, because they become very floppy and easily twisted. And when that happens, that's really dangerous and very painful, because the intestine is twisting on itself and can cut off the blood supply to that area and can cause necrosis of that area. So just to, explain kind of what can happen. So typical treatments, here we have my favorite approach, which is to use Miralax and Senna. So X-Lax, I really like X-Lax because it's the medication Senna. Senna is the active ingredient, and it comes in these little chocolate squares, which normally kids like to eat. They're very small squares, so it's not a lot that they need to swallow, and it's quite effective. And Miralax is a powder, of course, as you all know, and it can be mixed into some liquid, juice, water, really like anything that the kids will take. So the reason I like this combination is because Miralax is a medicine that makes the poop soft. So it softens up the poop, and then X-Lax works together by stimulating the intestines, stimulating the muscles of the intestines to push the poop out. So you need both together. You need to make it soft, and then you need to get it out. And especially kids undergoing potty training who are worried about letting that poop come out, this chocolate, these X-Lax, Senna, that can, I find it helpful because it kind of makes them come out. But you want them to be on the Miralax so that when it does come out, it doesn't hurt, and then they learn, oh, it's not so bad to go poop. I can do it. So of course, then trying as much as you can to make sure the kids eat a high fiber diet, drink plenty of water. Exercise is really good to help move things along. Enemas and suppositories, of course, nobody likes those, but they can be very important, especially when you have come to realize that there is, in fact, a hard ball of stool stuck down there, because even if you give Miralax and Senna, it's going to still be really hard to get that bottom plug out. So you need something from the bottom to get that out first, and then Miralax and Senna will work much better after that. And then some other interesting treatments. One of my favorites is anal Botox. So this is relatively new, and this is when Botox is injected into the internal anal sphincter, and that helps relax that sphincter so that the poop is able to come out more easily. It's a very simple procedure. It is, however, done under anesthesia. It's not long. It's usually done with just a mask. So sometimes you don't even need to put in an IV in these patients. But basically, under sedation, Botox is injected into 4 quadrants around the internal anal sphincter. And usually we do this every 3 months if it's helpful. And according to studies that were published, it actually has been very helpful for kids with severe constipation, for whom medication has not worked. So, it helps with decreasing the pain of bowel movements, increasing the frequency of bowel movements, and also helping with fecal incontinence and that leakage. So that is and we do offer this here. There are many centers around the US that do perform anal Botox injection. Some other things are pelvic floor physical therapy. So this is when you work with a physical therapist and you learn the biofeedback. So kids get to learn how, they're asked to squeeze and hold it, and then you can watch the strength of your contractions on a monitor. So, this does require participation and understanding and, being able to participate in it. And it does take, of course, a long time, as things with physical therapy do, but it can also be as a helpful addition to help kind of retrain your bowel to kind of be more, to fix constipation and have regular bowel movements every day. And then one more thing that can be done is what's called a mace. And this is a special type of tube that is inserted directly into the cecum. Sorry, I don't know if this right here. So this part of the colon is called the cecum. It's basically if you go from the mouth down to the anus, it's kind of like the first part of the colon. So it's connected to the terminal ileum right here, and that's the last part of the small intestine. And then there's a valve, and then it goes directly into the cecum. And then, so here is the colon, so the rectum, and so anus, rectum is over here. This is the sigmoid, and then this is the rest of the colon over here, and this is the cecum. And so, and the job of the colon is actually, once the poop makes it there, the role of the colon is to reabsorb the water back into your body. So this is really kind of like where constipation may develop. Like this is where it affects the intestines in the colon, not really the small intestine. So a mace is a little tube. It's kind of like a G tube, but it goes directly into the cecum. And there are various surgeries that can be done to do this. Sometimes they use the appendix to make a little conduit in which you put this little tube in. And that's performed by surgery. But anyway, once you have this mace, what you can do is just give a daily flush. Like you flush with 1 liter every day of solution, and you flush out the whole colon. And that can be also an effective way of treating constipation and making sure that it is cleared out every day and that this doesn't happen. And that, it's not as common as a procedure that is done as, for example, anal Botox, because it is quite invasive. I mean, it's a major like abdominal surgery. So, but it is possible to do it. And basically, that's all I have for today. I'd be happy to answer any questions.
Thank you so much. I did have one come in online.
Mhm.
They say, is using Miralax and Senna safe to use long-term as kids progress in age?
Yeah, and that's a great question and very common question. And yes, it is safe. For us in gastroenterology, we use it all the time. We use it for many years. I think that it is more important to make sure that constipation is treated and that this doesn't happen to the intestines, because the risks of developing severe constipation, it pose really severe risks like that dilated colon, the volvulus, it just perpetuates the problem. So Miralax is essentially a very safe powder. It just is a powder that draws more liquid into the colon. So that's how it makes the stool soft. And Senna pushes on the muscles of the intestine. So I do think that it is safe, and all of us in pediatric gastroenterology, these are number one. Miralax especially is the number one treatment, the first line treatment for constipation. Senna is number 2.
What are your thoughts on using like a daily fiber gummy?
Yeah, that's great. That's a good addition. I just think that sometimes it's not enough. You know, I mean, it might be enough for a period of time or at some point in your child's life, but you have to pay attention to the consistency of the stool and the frequency of the stool basically every day, every bowel movement. And I know that can be really hard, you know, to all the time be looking at the poop and at the consistency, but it really does reflect what's going on in there. And sometimes it's hard to know. So the more information you know, the better you may be equipped to, you know, give more Miralax at the right time. You know, and the fiber gummies, oops, sorry. Fiber gummies, I mean, they're great. And if you are able to give them to your child and they take them and they are having a soft bowel movement every day without any problems, and then great. Yeah, that's perfect. You can continue doing that. But just if there is some things like this that do develop, then it is important to treat it.
Thank you. I've got a quick question. Appreciate the slides. With regard to an elongated colon, have you ever come across that and considered like surgical intervention potentially there to shorten an elongated colon?
Yeah, I mean, that does also happen sometimes. Yeah, the colon can become tortuous. So, you know, they don't typically do a surgery like when they notice that the colon is even dilated to this degree, or elongated. The surgeons don't typically do an operation just based on that. You know, it is a high risk surgery and, you know, the volvulus may or may not happen. So I have never seen them do it kind of proactively. But of course, if episodes of volvulus do happen, then that makes it more likely that an operation can occur.
What foods do you recommend for constipation?
Yeah, great. So lots of green leafy vegetables and foods with fiber. So that would be things like any kind of vegetable and really any kind of fruit. Kiwis are really good. Prunes, dried prunes are good. Prune juice, sometimes apple juice, but I think like prunes work better. And watermelon is really great because it has a lot of water. And really any fruits and vegetables, those are the most important things. I think those are better than like multi-grain bread and things like that, because breads and carbohydrates can really contribute a lot to constipation. So as much as you can, water, fruits, and vegetables.
But kind of coming back to that Miralax X-Lax combination that you talked about, you know, sort of what's the best time of the day to start that? Like, and how long does it take to work in combination to produce the results?
Yeah, that's a great question. So I usually recommend to give Miralax in the morning and then Senna at night, and with the goal that there would be a bowel movement in the morning. Yeah, I mean, it can depend really on what is going on in the intestines at that moment, you know? Like if there is a hard ball of stool, you know, you may give Miralax, but, you know, it may not come out. It just may cause some bloating and some cramping because that hard ball of stool is there. If, you know, things are fine, you can give Miralax. Sometimes that may even produce a bowel movement within an hour or a couple hours. The Senna, you know, it depends also on how the child reacts to it. In some kids, Senna can cause some cramping and abdominal pain. And that also, of course, depends on how much stool is inside the colon at that time. If there's a lot, that can cause a lot of cramping. But typically my regimen is Miralax in the morning, Senna at night, hopefully bowel movement in the morning. Yeah, the following morning. And yeah, that's what I was gonna say. Yeah.
Hi, we have a 20-month-old and he will not take any type of a sippy or straw cup. He is very resistant to taking water. He won't take any other liquids like juice. So really the only way that we're able to get liquids into him is through a bottle. And he only wants milk in that bottle. So what we've been doing is trying to do like 2 ounces of milk to 6 ounces of water. But what we're finding is at max, we can get 24 ounces of liquid in him for a day. There's times where he won't even take 3 full bottles within a day. So we're really struggling with how to get liquid in his system. I'm wondering if you have advice for that. He is so young, so it's not something like we can force him to drink a glass of water or even take a sippy cup. So when I look at his constipation journey so far, that seems like one of the biggest glaring problems within his system. But at this point, we're completely at a loss of how to get liquids into his body.
And does he have constipation at this time?
He does, yes.
Okay, okay. So yeah, in terms of how to get him to take more liquids, unfortunately, I don't have any great advice on that. I think what you're doing is already, what I would recommend, and that is just to keep offering as much as you can. In terms of the constipation, you could add a little bit of Miralax into one of his bottles. Sorry, I keep pressing this. You could add a bit of Miralax to one of his bottles, and I think that will help. And then another option is there is another medicine that's similar to Miralax, but it comes in, it's like a medicine. It's called lactulose. So that is like Miralax, but it's not a powder. It's already like a pre-mixed medicine. But sometimes, depending on the weight of the child and how much lactulose they need, it's a medicine that's a lot of volume. It may be like 15 milliliters twice a day, which I know is also hard in this scenario. But you could try mixing that medicine also with his bottle. Any way that you could try to get him to take. And then suppositories for the constipation, not, every once in a while, I would say. The Senna, typically we start using it around age 2. I don't love using it in the younger kids, but your child is almost 2. I would probably wait a little bit. I would probably try first the Miralax and the lactulose, and then maybe try prunes. Maybe he might like those, chewing on little prunes. They can really help a lot. And they have kind of a similar effect like Senna. So maybe a little bit of Miralax in his bottle, like a teaspoon in a 4 ounces or so. And then try to give him some prunes to eat.
Last question.
Do you have a question?
How does gas or bloating correlate to constipation, or does it?
Yeah, great question. So definitely can occur with constipation. So if you have a lot of poop that is stuck in the colon, in the rectum, in the sigmoid, it's stuck in there. There is a lot of gas that will be produced upstream of that. And so, and it's going to cause pain and bloating because it can't get out, because the poop is stuck at the bottom and won't let it out. So that's how it's related to constipation. And sometimes I find that, if you are in such a situation where you have an impaction, a fecal impaction, and then you give a lot of Miralax on top by mouth before getting that impaction out, that can cause even more bloating and belly pain, because the Miralax is just kind of the powder there that's, sitting there and not really able to do its job because there's a lot of hard, dry poop that's waiting to get out.
How often is it safe to take suppositories?
I would say, once a day is okay. I wouldn't want to do it like every single day, once a day for years. It can you know, you might be kind of irritating the rectum if you do that all the time, every day. But if you are in a period where things are really tough and you need to work through this, like you could give one a day for a couple days. After that, I would say probably like once a week, twice a week would be okay.
Okay, now really the last question.
Thank you so much. So our boy has had a sink that, I'm sorry for my medical terms, the thing where you widen this sink, it's a
The
surgery.
sphincter, the surgery, sphincterotomy, like
Yes,
internal anal
Yes,
sphincterotomy.
yes.
Uh-huh.
When he was 2 years old, he's 6 now. And for a moment, it seemed to work. He could poop more. Now back to the same old
Okay.
problem.
Uh-huh.
The question is it possible that this thing's like closed up again, or could there be other reasons for that?
Yeah, yeah, this sphincterotomy, I think now with anal Botox being available, now people are doing more anal Botox rather because it's, you know, less invasive than a surgery than a sphincterotomy. So I have more experience with anal Botox than this procedure. But I would say yes, I think both scenarios are possible. You know, it may be that it has closed up again, like during the healing process. It has, maybe there was some regeneration in the area and it has closed now again and it's the same as it was before. You know, it's always possible there could be something new going on, you know, like something external compressing the rectum, or, you know, just worsening constipation in general. I would say you should maybe talk to your doctor about trying anal Botox and kind of like looking more at the kind of what might, if there's anything else that's going on.
Do you know if it's available in Germany?
In Germany, anal Botox?
Yeah, that's where we're from.
Oh, okay. Oh, so happy to have you here. But you know, I don't know 100%, but I can't imagine that it's not available. I think it's very, very widespread now. Well, and you can always come here. Yeah, I'm sure they must have it in Europe. I'm certain they have it.
Thank you so much, Dr. Amarikian.
Yeah, no worries. Thank you.
So I'm Margaret Reynolds. I'm one of the pediatric ophthalmologists here, and I think I've met most of you and seen most of your children, but I'm just going to talk about the ocular manifestations of DESSH. And I'll try to keep it brief and focus on some of the things that kind of have come up. But I don't have any conflicts of interest. So you guys are all very aware of what DESSH is, with a very variable presentation, and we kind of see that in eyes as well. But we're going to focus on the eye abnormalities. The WAC gene is widely expressed and including within the eye. And so the common eye findings, many of them are just kind of cosmetic, but kids with DESSH can have deep set eyes, they can have hypertelorism, they can have ptosis, prominent brows, strabismus, myopia, astigmatism, or cortical visual impairment. So we'll just briefly focus on each of these. But the eyes, this is just kind of a general overview of the eyes and the orbit. So the orbit is just the bones around the eyes. Here's the eyeball itself. And then this kind of tissue here is what we use to define hypertelorism. So deep set eyes really has no implications from an eye health standpoint, but this would be how we would measure it. And then hypertelorism is just an increased distance between the two orbits, so like the bones between the eyes. And this doesn't cause any problem with the health of the eyes. It does, I think, cause some of what maybe you all have run into with pseudostrabismus. So it can look like the eyes are turning in or going out, but they're not actually doing that. So
Ptosis can be a little bit more visually significant. So we worry about ptosis or droopy lids in little kids because if the lid is blocking the eye, then the kids can't see out of that eye and then they don't develop good vision. So the vision is really interesting because in order for the eye to develop 20/20 vision, the brain has to get 20/20 vision. So if an eyelid is blocking the vision for like the first 9 years of life, then the kids can experience some vision loss. Fortunately, ptosis is well treated with surgery. So usually if you have very significant ptosis, like it blocks the pupil before age 5, you do one surgery. And then after age 5, there's a different surgery that you can do to help with peripheral vision. And then prominent brow, kind of going through the list, doesn't affect the health of the eye, so we don't worry about that too much. Strabismus is also fairly common in our patients, and it's really just any misalignment of the eyes. We actually don't know what causes strabismus, but it can be from the eyes turning in, the eyes going out, and then there can also be vertical misalignments. You don't have to treat all strabismus. Some strabismus is improved with glasses. Some kids get improvement of their strabismus if they have one eye that sees better than the other by patching. And then for kids that glasses or patching don't work, then you can do an eye muscle surgery, which is outpatient surgery, takes like 20-30 minutes. It is under anesthesia, but it's same day, you go home the same day. And the kids usually recover really quickly and really well. Not everyone who has strabismus needs an intervention. It really just depends on how frequently the strabismus is manifesting. And so if it's infrequent and intermittent, it's probably not affecting the kid, it's not affecting the vision, so you might not even have to do anything about it. And then next, so needing glasses, kids with DESSH might be a little bit more likely to need glasses, but it's also really common to need glasses within the population. If you need glasses, then all you have to do is wear them, although that's maybe a little bit of the challenge. So not everyone who needs glasses can wear glasses for a lot of reasons. In this population, some of it might be kind of behavioral. We have kind of two options. So you've tried everything and you really can't wear glasses. There are centers, usually centers that focus on autism, have a lot of like behavioral type interventions. Nothing has, I wouldn't say there's anywhere that's like really focused on this yet, but our work here at WashU, we do a lot of refractive surgery, and I was talking about it with some autism experts, and they were basically like, we believe that that we could get a lot of these kids to wear glasses if you just did kind of intensive behavioral therapy. So that's, I think, not being able to tolerate glasses was a little bit of a recurring theme yesterday. So I think behavioral therapy is an important consideration. And if you, and probably an option for a lot of families. The next option is refractive surgery. So important to kind of know that glasses prescription over life changes a lot. Usually little kids are farsighted, and then by the time you're a teenager, a lot of times kids are more nearsighted. And then the nearsightedness can kind of progress until usually like 20, 25 or so. So that's why, you know, if kids need glasses, we're not doing refractive surgery on everybody. But if kids really can't wear glasses, then we do refractive surgery for two reasons. One is just because obviously we want everyone to get 20/20 vision. And then two, we have noticed that kids who have kind of secondary behavioral difficulties, imagine you have behavioral difficulties and now you can't see. The decreased vision seems like it complicates a lot of behavioral problems. That being said, refractive surgery, obviously a lot of risks and benefits. So you kind of always have to weigh the risks and benefits. But something to kind of file away. Refractive surgery isn't done everywhere, but something to file away and kind of consider if you're really struggling to wear glasses. And the refractive surgeries are kind of, they can treat nearsightedness, they can treat farsightedness, they can treat astigmatism, and there's kind of different surgeries, different risk benefits. So just an important consideration for everyone. And then again, if you think about just some of the autism centers have certain behavioral focused interventions, honestly, like toileting, if you have trouble with glasses, there can be certain types of behavior interventions that might be beneficial at like autism centers. And then lastly, so cortical visual impairment is kind of a newer thing in the whole field of ophthalmology. As a matter of fact, it doesn't have a definition. So it's a priority of the NIH to come up with a definition of cortical visual impairment. I would say last year that was a recurring theme in the clinic, but I think maybe it was just active on the parent group. And I wouldn't say that we necessarily saw as much or as many questions that didn't come up as much this year. But essentially, it has been described in kids with DESSH, but a child who has cortical visual impairment has vision problems that are caused by their brain rather than their eyes. And so in order for people to see, the eyes have to send a signal to the brain, and then the brain uses those signals to essentially form images and tell you what you're seeing. So in kids who have CVI, the brain has trouble processing and understanding the signals from the eyes. And so this was honestly just a very fascinating study, and it just shows that as we kind of have studied CVI more, the kids who have CVI, we know that things are just kind of wired a little bit differently. So this study just compared like the connectivity in the whole brain between, this is a person who can see, a person who's blind just from the eyes are blind. And then this is a person whose eyes are okay, but they have CVI. And so whole brain connectivity just seems like it's very reduced in individuals with CVI. So I put my email up here, and at this point, I think we can take any questions and go from there. And feel free, you can send emails or if you have any questions in the future. So. Yeah, no problem.
All right, I'm gonna try not to cry, but I'm a crier, so I'm just gonna warn you that's probably, I'll be in tears in a few minutes. So thank you so much for having me, Caitlin, Emily, and the DESSH Foundation. My name is Kelly, and I'm a DESSH mom. My sweet Leo, my sweet love Leo, as I call him, is 14, and he is at home right now. Unfortunately, couldn't make the journey here, but I'm really happy to be here to share with you my journey. And today, what I'm going to talk a lot about, you'll hear me talk a lot about Leo, but you'll hear me also talk a lot about my journey as a parent, as a mother, because it's something that I really struggled to find connections and people who I could relate to. It's a really lonely journey when you go down this. And so I hope that for some of you in the room, you can find comfort and connection with that. And for those of you online. So like many of you, I got married and got pregnant really quickly and had so many hopes and dreams when I got pregnant, and never really thought about that there would be anything to worry about. And so I was pregnant. There's Leo in my belly. Leo William Bookout, he was born 6 weeks premature. Which again, wasn't really worried about that. I mean, so many kids are born premature these days. It was a traumatic birth. He was in the NICU for 9 days and born at 5 pounds, 2 ounces, but he came home and I was relatively zen, thinking, okay, we're gonna now go down the path of normal motherhood. And his early days, in my view, were quite normal. I had a really good friend, and I know she's watching online right now, had her little boy about 6 weeks early or 6 weeks earlier. And so we had two boys side by side. Leo was a really good sleeper. He was a really calm baby, so he wasn't colicky like, you know, you hear some of them, but he did well. Some challenges with breastfeeding, but I think that kind of goes with the territory. And so this is his little buddy, Aiden. And one of the things we did start to see with Leo earlier on, this is probably about 3 months, is the shape of his head and his skull, and was quite flat, and his brain and his skull was quite smaller compared to other children. Again, I wasn't really worried at this point because you know, he had to get a helmet, and we went to the helmet clinic, and, you know, lots of little kiddos need to get a helmet. So off we went, he got his helmet and wore that, and it worked pretty well. So it was at 10 months where things changed. And I'll never forget the day I was standing at the front door, and Leo's, our grandmother, my mother-in-law at the time, said, you know, I just don't think Leo is progressing the way that he should. And I was like, well, what do you mean? Like, kids all progress at their own stage. Like, that's what I read in the baby books. I'm not going to be stressed out about this. As I started to talk with some more and more folks in my family, the feeling was that there was something that wasn't right. I mean, Leo wasn't pointing, he wasn't babbling, he wasn't crawling. But again, he's going to come along. And so we went down the path. And what's interesting and what I didn't really appreciate, and we've got some really smart doctors in the room, so I trust them. But at the time, Leo's doctor was also like, no, he's fine. You know, he's going to progress. Your family is overreacting. And we had a healthcare, a surgeon in our family, was Leo's uncle, that said, no, I'm going to go with you to the doctors, and that you need a pediatrician. So I'm from Canada. I forgot to say that. And, you know, when you don't get a pediatrician unless there's special needs. So we got a pediatrician, and she said, yes, you know, Leo has microcephaly, a small brain. We were worried about that he had an MRI. We were worried about whether or not his brain was small, therefore there'll be likely some intellectual challenges. He had hypotonia, and then they diagnosed him with global developmental delay, which is the most unsatisfying, you know, diagnosis you could get, because it feels like this is way more than a delay. What does this really mean? And so that's what we had for the next several years. Leo got a walker. He didn't start walking until about 30 months, so he was at the end, but he got a walker and never crawled. So he scooted, and he still kind of scoots to this day, but he never crawled, always scooted on his bum. So 14 months was the next sort of really big milestone that sticks in my mind as a mother. We went to see the geneticist at the Alberta Children's Hospital, and at the end of our appointment, she said, you need to be prepared. Your son may never walk, he may never talk, and you may never know why. We were shocked. We were, Leo's dad and I were mad. We walked out of there like, what? Like, you know, like, how could she say that? For me, as Leo's mom, you know, and I'm here to share my journey as his mom, not to speak for his dad, but when we got the initial diagnosis of global developmental delay, like Google became my best friend, and I was Googling, and what do we do? His dad was in a little bit of denial, right? Like, yeah, okay, I think things will be fine. And there's a really lonely path to go down when you're going through this, even though you're together, but you're not, because you're both on your own journey with acceptance and going through this very traumatic thing. But this is what his dad needed to really realize that we have a serious issue or challenge that we are going to face in our future. So from there, it was a lot of ongoing daily struggles. You know, I wasn't equipped to stay home. I was a career woman. That's the gifts that I could bring to Leo, was going to work and being able to provide. his dad, the same thing. He had all the interventions we could get. We went to daycares, got special extra help, but it was a really, really significant challenge for our family. My mom, who's here with me today, she lives out of town. We didn't have a huge support network. What became really clear to us as a family was that we couldn't do it on our own. We brought in our family, her name is Anna. She came over from the Philippines and is like a sister to me, is the strongest woman I've ever met, way stronger than I ever will be, and became part of our family and helping us care for Leo and gave us a lot of strength and a lot of support that we needed with our son Leo. So we'll skip to 3 years old. We had taken Leo for an autism diagnosis, and I remember clear as day, he was rolling around on the floor, and they were like, oh, made that eye contact, doesn't have autism, right? So they're like, oh, because Leo's very social. He makes eye contact, very social with adults, not as much with children. So we're like, okay, cross that off the list. But he was nonverbal, saying we're global developmental delay. We had early interventions, and we really had to advocate for that. But we did get a lot of support: speech therapy, physiotherapy, occupational therapy, other people coming to the home. Before we got Anna in our family, we had therapists going to Leo's daycare, but things were hard. The daycares couldn't manage Leo. We couldn't do the normal things as a family. I think that was probably the hardest part for me as a mother. I couldn't take him to places where my other friends were taking their children on play dates and things, because Leo's behaviors were getting harder and harder as each day passed. So we continued on the journey, and part of that journey was lots of doctor's appointments. Before I get to that, I remember Leo in kindergarten, and he went to a special needs kindergarten, and we were sitting down with the parent teacher at the end, and the teacher said, like, it's really hard for Leo. We really can't get him to concentrate. And she was trying to be so patient with us and kind of get us to the point. And finally, she was like, I think your son needs medication. And we're like, what? That wasn't something that we had ever really thought about, even though you'd think we think about it, but we didn't have really a diagnosis. It was GDD. We didn't really understand. And so we started what was still a medication roller coaster. And I wish that I had kept a journal of every medication that he was on and back on and off. And it's really complex cocktails and really hard decisions as parent to make, because nobody wants to put their child on medication. And so that was something that we've had to really, as a family, work through. Lots of doctor's appointments, lots of therapist appointments. Leo, Leo was fairly nonverbal until about 5. He started to say a few words. But he was very hyper. Like, you had to watch him 24/7, which is why we needed more care. You could not take your eyes off of him. Very impulsive. I think I've got this. At the age of 5, a doctor said, no, he definitely has autism. I don't care what that other person said, go back. We went back, and okay, now he has autism. Okay, didn't really change anything. Nonverbal, GDD, and he was in kindergarten. So this was him. And it's funny because to me, I think he just looks like a normal little 5-year-old. But I know he does have some of the facial features. I still don't see them myself, but the geneticist says, yes, he does. And so the biggest challenges for Leo and what we face is very obsessive over things. So cars, wheels, trains, obsessive, aggressive. And so throwing, hitting, we were in fight or flight all the time. You didn't stop. I mean, until you put Leo to bed, which was the saving grace, because you did put Leo to bed, he did sleep. But we had to have a lock on the door, and we woke up for 10 years every morning to bang, 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 bang. And can you imagine you're asleep and like, that's how you wake up for 10 years because we couldn't allow Leo to leave the room himself. We weren't sure that he would come down to our room and get us. And so for his safety, we had him in there. You in the house, if there was something on the table, you better be sure he's going to take it and throw it. So this was Leo, I mean, aggressive, impulsive, very anxious, very, very anxious little kiddo. And so this is Leo, you can see in some of his cars. He loves cars. And I mean, the challenge as Leo got older was because he's very impulsive and he gets so excited, he throws cars and they're gone. And so literally, I kid you not, we've probably had over 2,000 cars, 3,000 cars, and I'm not sure how many we have left. He'll develop his favorite and it'll be the one that's the hardest to find in the store, right? And that's his favorite. And because he's so obsessive and compulsive, it's like 4GT, 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 right? And you'll come back with a Honda or like Porsche. No, it's the 4GT that he wants. And so, and as a parent, all I wanted to do as a mother was give my son what he loved. And so the things that he was the most obsessed with or that he valued the most are the things that I wanted to provide for him and make him happy. Life, it was very much a blur as I think through sort of like he's 14 now. And as I go through, he you know, his cars, most of it, taking him to the doctors, really hard, as I'm sure all of you can well imagine, and even coming today, a fear of the doctor. But in this little picture down here to the right, I mean, one of the things, Leo doesn't experience pain in the same way that most of us probably do, and similar to a lot of the kids and parents I've talked to. I know a lot of kids don't, and that's really hard as a parent because you don't ever want your child to be in pain. And there was one time we've been camping, and of course it's a long weekend and we're 3 hours away from home, and I was changing Leo's diaper. He's probably about 6 or 7, and I don't know, I'm a woman, I don't really look at these things, but his dad walked by and it's like, oh my God, like one of his testicles was like huge. And he's like, didn't you notice that? I'm like, no, like, I don't know how big it's supposed to be. Like, I don't really know. And we took Leo threw him in the car. Well, we took pictures, sent it to medical people in the family. You need to get him to a hospital. And so we got him to a hospital, and he ended up, they were afraid it was, it was something with his testicle, but it ended up being a hernia. And the doctors were like, I don't know how your son lived with this pain that he could be in with what he's experiencing. And so he had to have surgery. But taking Leo to several times to the hospital for different things, up at the top, taking him to the dentist. Leo has lots of dental issues, always very, very traumatic. And at the point now, he needs to be put down when he goes to the dentist. He just can't cope. And as a parent, all of these events were extremely exhausting. And I don't think that, and we recognize it because we're going to do whatever we can for our children. But it was really, really hard on all of us. It was very isolating, or has been very isolating for me as a mother. As I watched my friends and family with their children and not experiencing the same things that they experienced, not developing the bonds or the friendships of other friends who have a huge network of other families. My son Leo didn't like to leave the house. And when we tried so desperately to take him out, it was a disaster where most of us ended up all in tears, or at least I for sure was in tears, because Leo resisted, and Leo was anxious, and Leo would throw, and Leo would hit, and he would be very aggressive. And being out in public was really hard because you get a lot of judgment out there, a lot of people looking at you like, control your child, what's wrong with your child? And you are just trying to give your son or daughter an experience so desperately that you want them to experience, but also for yourself. But our life was really isolated. aside from work, which for me was personally my escape, a lot of grief. I think my counselor or my therapist would probably still say today that I'm not accepted it. I believe I have accepted it. It doesn't mean that I'm not going to have bad days and have sadness for myself, for my son, and for the world, the life that I had dreamt for him. But I very much accept where he is at. Exhaustion, complete, utter exhaustion. And survival mode was really the mode at which our family was in for many, many, many years. Let's skip to 2020, and we all know what 2020 was because it was COVID. It was also the year prior to, in 2019, our geneticist called, and she would see us every four years-ish. We'd bring Leo in, and she'd say, you know, there's something there. I don't know what it is, but I just am confident there's something else there that we don't know yet. And so she said, there's this new testing that's available. We have to apply for it. I think your candidates said, but again, don't have high hopes, probably not going to find anything. And so, okay. And we did the testing as both of his parents who went and did that. So 2020, we got a call. They found something. And you're like, get out, right? Because, you know, I trained myself to think I'll never know. And Leo was diagnosed with DESSH at 10 years old. And it was bittersweet, as I'm sure all of you can attest to, because you're like, okay. And then you get on the computer and you don't know anything. But at least you have something that's more than global developmental delay. It feels more legitimate in some ways. You know, neither his dad or I were carriers, or, you know, they had said it happened in the womb. It was a mutation, or it wasn't your fault, right? Because I'm sure a lot of us think like, did I do something wrong in the birth, or was it because he had a traumatic birth? Should I got the C-section? Should I push this? Like, you just for years question yourself. And so there was a little bit of peace that I could have, that this was just this wasn't caused by anything. This was a new chapter for me because Leo's dad and I separated, and so life, you know, life can be really hard, and it's by no means Leo is the reason why, but I want to recognize the challenges that it puts on families as you have to go through this incredible challenge. And I moved into a new home. This was my new home, and with that was new challenges because we had Leo 50-50. And Leo adapts very well, though. It's like, okay, mommy's home, daddy's home, as long as there's cars. He was pretty well happy, and we made that transition. But it was really hard because he was getting older now, and the aggression was getting worse and worse. He was pulling or hitting quite a bit, hitting me, hitting himself. So those self-injurious behaviors. At the very top was he kicked his bare feet through a glass door, and so had to go and get stitches on his foot. This was me in the bottom right hand when Leo had a cold during COVID and couldn't go to school, and it was at the time where you know, things were fairly shut down, as I'm sure in certain places they were all over. And in Canada, where I was at that time, it was shut down. And so much so that even our nanny, God bless her, Anna, wouldn't come into the house. So I was locked in the house by myself for 3 days with Leo, and almost did not survive that. Towards the right, you'll see on the bottom is just the kicking, and this was all over. This would happen in an instant. This would just be Leo so aggressive and so angry, he would kick holes all over the house. And so it started to really escalate, and I started to really have to think about things. This is what I call the TSN turning point. TSN is a sports network. I'm not a sports person, but this was a turning point because this picture was at the psychiatric ward. And it was the picture that I took from my bed as I had to go and get some help because I had a friend pick me up and put me in the car and say, no more. You're so tired. You need a break. You can't do this anymore. And so I thought, when I was laying in the bed at the psychiatric ward, I thought, this is a really pretty, I feel at peace with this curtain. And I took a picture of it, and it was the moment I knew that I couldn't care for my son and by myself, that I just couldn't do it anymore. And so I had to face the unimaginable. I had to make the decision that, tell his father I couldn't have Leo 50-50. I knew that would change his life. You know, I was ready for Leo to go into a home, and so he's on his journey that he needed to go on. And so eventually, Leo did move into a home. We call it the new home. Leo still calls it new home, new home. And this is for the Society of Treatment of Autism in Calgary, Alberta. He originally started out in more of a group setting where there was 2 wings and boys and girls. He's since moved into, they have a bungalow, and it's a much quieter setting. And the pain, this isn't a decision that, and I hope that so many of you don't need to make this decision, because as I'm here and meeting the other children, it just gives me so much hope that Leo will continue to develop. And I know that not every child with DESSH has to go down this path, but I want those parents who are really struggling not to feel the shame and the guilt, or nobody talks about this. Nobody talks about how do you make this decision. And it was a really lonely one, and a lot of pain and guilt. And over time, Leo has adapted really, really well. He, so much so he doesn't want, I can't bring him to my home anymore. I've tried to do that. He doesn't want to anymore. Actually, he doesn't want to leave his new home. New home, new home. He likes to go for rides and drives and get ice cream. And the beautiful thing is I can visit whenever I want, but this is where Leo is comfortable and he's happy. So what works for Leo very much is structure. He needs to have the structure. And this is why it was important for him to be in the home that he's in now, because he gets that structure and there's 24/7 care and watching over him. He needs the routine. Positive rewards, he really responds well to that. So, trying to get him, like any child, to eat his vegetables and try to eat more than just French fries and cheeseburgers, is, giving him a positive reward, whether or not that's a candy or a Hot Wheels car. We actually used Hot Wheels cars for potty training. We used, and it took Leo, he's finally out of potty train during the day at about 8 or 9. And about 10 or 11, he was in diapers in the evening, and he still has accidents when he wakes up in the morning. But it's great not to be worried about diapers anymore. Visuals, so visual stories, visual pictures of what he can expect. He has a lot of anxiety, and so being able to show him what he can expect in a picture and talk him through, like, we're going to go to the doctors and this one's going to look like here, and then we're going to go here, and then we're going to go here. It really gives him a lot of comfort and certainty around what he can expect. But he's very much gets overstimulated very easily. And so that's part of the challenge with him now is, and as he's getting more aggressive and he can't control his emotions and he can't control his impulsiveness, he knows. He's very smart. Any car, if you're driving on a highway, he knows every make and model of a car, and he knows it. Like, I can hardly even see the car and he knows what it is. It is outstanding. Maps, you take him somewhere once and he knows the word new. And so it was a concept we really had to teach him, because he's so obsessive compulsive as well. If the bus driver, we'd get a call from the school, Leo had a really hard time with the bus driver today. The bus driver, there was construction, the bus driver had to go a different route. We're like, you have to tell Leo, new route. So he understands, okay, it's going to be different. One of the things is, for his hitting, it was probably the hardest part, right? And when I go visit him now, he persevere. I'm going to say the word wrong. Perseverates a lot. And even like, no hit mom, no hit mom, no hit mom, and no hit mom, no hit mom. Right? And he can't control it. Oh, sorry, mom. Like he knows, and I can see it coming, or we'll just be laying or sitting next to him, and out of the blue, it's just whack, and he can't control it. Driving in the car with him, I used to at least just pick him up by myself, and I knew I was taking a risk every time I did it. And the last time I took him for a drive by myself, we were in the car and he's always in the back seat, and he just went over and pulled my hair. Like I thought, oh my God, I can't. That's the end of that, right? And he knows. He knows that he shouldn't be doing things, but he can't control it. And his mind, he can't get his mind off of certain things. It's the hamster wheel where his mind is, he wants something or he wants a picture. And so one of the things I wanted to share, if you do have any, challenges with dents on your walls, or Leo threw everything imaginable, and Hot Wheel dents all everywhere. I started printing pictures. Because again, as a mom, all I was doing was like thinking, what can I do? And laminating, because Leo also loved the effect of ripping. So I started printing pictures, and they became a security blanket. Even to this day, it's something that we still do. And it's one of the things, if you look on my phone, you'll see just pictures of cars, because you sit there for hours as he scrolls on my phone to find the car he wants. He knows how to save it on my phone, and then he says picture. And then he says, laminate, right? So today, Leo is 14. I would consider him moderately verbal. I'm amazed, and again, so hopeful as I see and meet other children here and how they're able to progress and speak. Leo doesn't have conversations. Leo is very good at expressing his desires and his needs and his wants, which is something as a mom and for a child that was for so long unable to express what he wanted. I am so grateful, and sometimes probably given too much to the things that he wants, because all I can think about was there was a time I had no idea. Leo couldn't tell me he wanted French fries. And so if he wants French fries, he can have French fries for 5 days in a row. I don't care. He loves the cars, trains. Now it's sleep trains, like literally on YouTube, we'll just be mesmerized with watching trains on the video. Extraordinary sense of direction. He's very impulsive, has high moments of dysregulation, which is why he needs to be cared for. I tried to take him to the zoo the other day, and I can't take him can't take him by myself. And so I have caregivers that come with me, and Leo is smart. He knows the word trade. And I'm in the line trying to pay for the tickets, and he brings the caregiver over. Trade, mommy trade, wants the caregiver to stay here and mommy to go with him. Well, I had to pay. And so in that instant of a moment, it just set Leo off, and Leo's hitting and kicking, and I just purchased the ticket, and we have to go home. I'm a mess. I'm in tears. Everyone's looking at us, and it took me a long time to stop worrying about what other people cared. Like, I still get very emotional, but I very much want to, as much as I can, want the world to see Leo, and want the world to learn to accept Leo. And I want Leo to be able to do the things that he wants to do, which if it means going to Home Depot and pushing the cart around, literally that's what we do. My mom said, you better start going to some different Home Depots, because kind of worried that they might, like we are just roaming the outside, pushing the carts, and then Leo'd want to trade carts. He's happy and content, which is all I can ask for as a mother. When I leave, bye, mom. And sometimes I get there and it's like, no, mom, and I'm like, okay, starting to be a teenager. He loves school. He goes to a phenomenal school for special needs. He was suspended in grade 6. He was in a special class, but they couldn't handle him, and so they suspended him. And so lots of challenges to go through. We're working to really to expand his interests because the doctors are worried that he doesn't like to leave the new home. He wants to stay there, and the doctor's worried about him becoming very isolated. And so we're trying to get him to leave the house, go to the park. And he's just very rigid in the things that he wants. So me today, I'm really learning to find the joy in life. It's been a long road. I have let go of expectations. So when I go visit Leo, I know it might be for 2 minutes, it might be for 2 hours. And I have to go with no expectations because it would kill me when I did, because I'm not in control. And Leo, I want the best for Leo, and that might mean that we have one moment together and I might need to leave because he's over-regulated. I have a really special bond with him. And so my biggest fear, of course, having to make these decisions was how do you, am I a mom? Like, I'm not giving him a bath every day and I'm not picking at his clothes. And then when I see what they put him in at school, I'm like, those aren't even his clothes. You know, like, and I tell the teachers, I swear to God, we have really nice clothes for him. But he doesn't care. He's happy that nobody cares. And I'm still mom. I've recently transitioned from mommy to mom, and I'm hopeful. You know, my life now involves, you know, even though I travel a lot for my job, and it's probably what has saved me. And Leo will call me, and we managed to have a 24-minute conversation. It wasn't a conversation. It was more like, hi, mom. Mom, French fries, ice cream. So we have Skip the Dishes, which is DoorDash, similar to many of you. And, you know, one of the things he does call me is to ask for his order of his food. So the other thing I'll say, which I wanted to mention is, you know, the technology is very technology savvy, and he had an iPad, which I have tested Apple's theory, or the Apple eye care, when they say you can have unlimited. I literally have, last Christmas, I bought him a new iPad because he just saves pictures of cars. And I kid you not, within the first week, I was in there twice, and the first month it was 5 times that he got a new iPad. But Leo gets so excited and he wants the iPad, he injures himself. And so he was cracking the screens, even though we had protectors and all of that on there. So he's not able to have iPads at the moment because he just can't manage it. It gets overstimulated. So that's, you know, all I had today to say. I'm really, again, thankful to be here and to meet all of you. I hope that we can work to get Leo here next year or in another year. And I really hope to stay connected with as many of you as I can, because I'd love to, part of what I would love to do is just help other families as they go down this journey. So thank you.
Okay, everybody, we're going to get back into the swing of things and start up once again. We have a few more talks and only one more hour, maybe and a half. So I'm going to hand this over to Dr. Glazer right now, who was gracious enough to come back and speak with us again. Some of you from last year may remember him, and others will be glad you heard from him today once he's done. Dr. Glazer, thank you.
Great. So sounds like I'm on. Can you hear me? I do have a softer voice. All right, great. All right, so I'm a pediatrician and a child psychiatrist and an adult psychiatrist. So I do mostly take care of behavioral issues. And I heard that maybe a few of your kids maybe have some behavioral problems. Most of them are perfect though, right? All right. Well, let's talk about, this is the Facebook webpage. So this is public domain for those, some of your kids might be in this picture. But I thought my first thought was like, how did they get them to stand that still for that long for the picture? That in itself is a rare miracle. Yeah, oh, that's why. But you see, there's this one that's kind of like, oh no, not everyone wants to be in the picture. All right. So, but I bring this up in part because even though they may all share the same syndrome, they're all going to have different behavioral phenotypes. That is, they're all going to have different behavioral problems. Some may have some of these diagnoses that I mentioned, some may not. And that is part of the joy as well as anguish of having a child on DESSH syndrome. Here are the main ones that I could get out of the literature from what I've known, as well personally from talking to Dr. Marwan and Shinawi and all others. Anxiety seems to be all parts of the year, or I'm sorry, all parts of the life. ADHD is one that we see a lot early on. Aggression can be part of the way your child behaves to you when they can't communicate, or there could be other reasons. A lot of the patients, in fact, I would almost encourage everyone to get screened for autism spectrum disorder, just because that can be a treatable aspect of this. And then we sometimes do see mood swings or tantrums, which are sometimes, we don't call that bipolar anymore. We call that DMDD. So some of you might get that diagnosis. And then not on this list, but anxiety and depression will probably be a major part of their middle school and high school years, because that's just about when the brain starts to kick in that, oh my gosh, I'm different than the other kids my age. Oh, I'm getting bullied. And a lot of things might come in. So I can even talk about that. Now, one method of behavior I do not recommend is the Walmart method. Have any of you had any Walmart moments with your children? All right, and then you get those looks from other people in the store like, can't they discipline their children? I'll tell them how to raise. They might even come up to you and give you advice, and it's like, you know, pretty useless. But anyways, all of us have had those Walmart moments with our children. I have 4, and I have had Walmart incidences with all of them. But I guess one way to avoid that is just not go to Walmart. Who avoids going to Walmart? All right, so there's a solution to the Walmart therapy. All right, now, one way to get behavioral management is to get professional therapy. And I would say if you have a kid that's moderate to extreme in their behaviors, you want to get professional help. Because no matter how good of a parent you are for your other kids, this will be your most challenging child. So the 3 most that we talk about are parent training, very useful for the ADHD, ODD, and DMD diagnosis. It basically teaches you, hey, what are some other things you can do that you don't already do that might help? We'll discuss a few of these during the talk, and I can answer questions about them. The other 2 are child behavioral therapy, various aspects of this, but it basically teaches you different behavioral theories you can try on your child to see if that helps them behave. And then finally, as you get to older kids, cognitive behavioral therapy will be the main behavioral therapy for like your teens or adults with anxiety and depression. And it teaches them to use their own brain to kind of get out of anxious loops and depressive loops. If you do end up having the diagnosis of autism spectrum disorder, it does, in most states, it qualifies you to get applied behavioral therapy. It's probably the best therapy for aggression or irritable children, where it's, you know, and I've had these families where they're in the appointment or they've called me in emergency. I just got beat up last night. I'm not sure what I'm gonna do. Should I send my kid to the hospital? So hopefully you guys never go through that. But if you do, ABA, especially in-home ABA, is probably the one best way to attack that. And that can be 20 to 40 hours a week. It's very intensive, but very successful. All right. And I'll take questions at the end. So hopefully we can get through these with a lot of time for questions. And so parent-child interaction therapy is another parent training that involves the child themselves. It's very successful, but we don't get many insurances to pay for. So right now it's more of a research tool. We've used it a lot at WashU in research studies, and it's a great way to do it. But you can also find some trainings online that are free, some that cost money if you do think you want to do some form of parent training. Behavioral therapies help with a lot of different behaviors, not just aggression. It can even help you, like say you're having, I have a lot of my patients on the spectrum, for example, that just will not go to bathroom anywhere except for the one toilet they're used to doing it when they learn to use the potty. So what happens is they retain their stool at school, and then they become full of it, so to speak, and then they end up in the hospital needing a clean out. So sometimes behavioral techniques can help you get out of that symptom. And then some of our kids also do have some self-injurious behaviors or very poor tolerance, frustration, and a professional behavioral therapist can help you with that. Now, there are add-ons that I call add-ons because they're not traditionally behavioral therapy, but they help a lot of my patients. And they basically come down to three things: occupational, speech, and physical therapy. And actually, what are the three therapies that are most likely taken off if you go to elementary school? Occupational, speech, and physical. Because they set goals that maybe don't match your child, and they just say, oh, they graduated, they don't need it. And yet a lot of my patients, I have to write letters to the school saying, please reinstate this. This helps them with a lot of other things just than. And so the way I break it down is if sensory issues are a trigger for their extreme behaviors, you want to work with an occupational therapist. Say they only will eat one food and you try to introduce a new food and they have a tantrum, you know, but yet you want them to eat more, that occupational therapy can help you with that. When communication is an issue, so if your child can't tell you things with words sometimes, or especially for a lot of our children, expressing their emotions can be hard. They can tell you what they want, but if they come to like an overwhelming, say they had a bad day at school, they don't have the words for that, or their brain is still processing it. And so how will they show you they had a bad day? It'll come out in their behaviors. So sometimes speech therapy or assistive communication devices are the best way to get your child to slowly be able to express those things instead of showing you with extreme behaviors. And then finally, just any kind of way to dispel energy is good for a lot of kids with ADHD. They sleep better at night. They do better in general if they have a lot of activities. And what have they taken out of most school system? Well, the physical education. So you have to add that back in other ways. Physical therapy is a good way to do it, but I also encourage a lot of sports and outdoors exercise if your children are tolerant of that. Now, perhaps the most universal therapy for kids right now is iPad therapy or iPhone. I don't, you know, most doctors are pretty, well, you know, we don't like it. We know that there's data already to show that the more screen time you have at any age is bad for a kid. Some amount is good. Yeah, if I'm looking around at the kids here, they're all on iPads. It does keep them entertained, but the trouble is it's super hard to take them away from it then. If it's time to learn something else, they're so obsessed with what they're doing. And if they're old enough to say it, they'll even say, I haven't finished the level yet. You know, they have all these reasons. So I think finding that balance is going to be important. I think you're still going to need it in your lives in some ways, but making sure you control that iPad or iPhone, make it child friendly. I always say you have to tailor it to the kid as well. I have some patients that certain apps set them off. So especially if it's like a video game kind of app where there's like an easy fail rate, they will have rage quit, as they say. So sometimes just saying, that's not a game you can play. That can be a great solution. For others, it's like, you can play that game you're obsessed with, but we'll put a timer on it. And I also encourage you to use visual timers, or some parents are savvy enough to get timers that time off after a certain amount of time. Now, you still might get a tantrum at the end of that. The visual timer is probably a little better because do any of you use those visual timers? You can buy them on Amazon, where they show very graphically like a red line that's slowly getting smaller and smaller. And the child will slowly learn that they have to be off by the end of that. All right, so let's talk a little briefly about practical behavior management, because a lot of times when families and parents are asking me, what do I do? They want to know, what do I do at home with this behavior that really is not addressed by any professional? I want to know what is the best way to intervene. So that's why I call it eclectic therapy, because you kind of have to learn about a lot of different things that people do and pick out the ones you think either are going to work, or try them on your child, your adolescent, and see if it actually does work. If it doesn't, just drop it, because there are a lot of books out there that claim they have the solution for your difficult child, but they don't. And especially since children on the DESSH syndrome are so unique, they are not going to understand how unique that brain is. Some brains are different than others. Now, I always say the best place to go for eclectic therapy is start with your support groups. So just like you guys are doing already, you're talking to each other, you're sharing your experiences and figuring out what worked. You know, make sure you have friends with someone that's maybe a couple of years older than you too, so that you know what to anticipate as your children get older. Book therapy is also good. I'm going to mention a few here in a second, but finding a good parenting advice book and that works for your child is going to be essential. And I would say go through these books, not attempting to do exactly what they do, but to pick and choose out of there what you think is valuable. And that's what I'm going to do. So one of them, there's many, many, many of them, but one of them is Raising the Spirited Child. I just bought this copy, so if anyone wants it at the end of this talk, they can come down and get it as a free gift. It is about it's about like relabeling what's going on, instead of like a psychiatrist where we give all these labels and it's all kind of negative connotation. You have ADHD, you have autism. It says, let's just call them spirited. Spirited has a little bit of a more positive tone to it. And it makes you feel, it's like language smithing to make you feel that there's solutions, there's hope. And that uses these 5 tenets: that you're not alone, that you did not make your child spirited, so it takes away some of the guilt of parenting, that you're not powerless, that it gives you back some of your, if you have a strong-willed child, I would say you have to have at least one parent who's stronger-willed. And then permission to take care of yourself, very important. And I would add to this, permission to take care of your other kids, because sometimes your squeakiest wheel is going to demand most of your attention. And then celebrate and just enjoy the delights of your child and their spiritedness as well. So if you like that philosophy, come by and get the book. I like one of the concepts in this is choose your battles. You're not going to solve every behavioral problem. So you have to choose which ones are either the most dangerous to your child or the most important to you. All right, here's another one that I also have a copy of up front, Parents' Guide to Self-Regulation. This one's probably a little better if you yourself feel like, boy, my parents really messed me up. They were terrible parents. So if you have that feeling, or if you just feel like, I'm always feeling dysregulated myself as a parent. This would probably be a good one because it teaches you kind of how to learn to regulate yourself and then how that's going to flow downstream to your child. Now, obviously, your children, they have a little different genetic makeup than you. So it's not going to just flow down that easily. So that's why I would say this is probably not as relevant for families that have a child with DESSH syndrome, but still may be useful for you if you yourself feel overwhelmed as a parent. And I mentioned already the strong-willed child. There are some books out like that. I think what parents need to learn is they do at least have one parent that's stronger-willed at an early age. Otherwise, your child will quickly learn you're both pushovers and just keep pushing that border. Now, that's not as big of a problem when they're younger and they can't hurt you. It's a big problem, though, when they get older and they're stronger and they can hurt you. So you kind of have to establish up front that there are going to be lines that you draw. And by the way, I do like if parents are married or live in the same house, I think it's really good to try to get on the same page, but it really is useful to have one parent that's a little more strict and a little more lenient because they show that that works actually quite well. 2 strict parents and 2 lenient parents are not as good as one. So, but just make sure the lenient parent still has to do some of the work. So, all right. So you'll, and then well, I guess the most frustrating for me as a clinician is that sometimes when they're divorced, they'll have the strict parent's house and the lenient parent house. And of course, your child loves being at the lenient house and has all the outbursts at the strict house. And yet that strict house parent is doing the better thing for long term. You might not read that in a lot of the politically correct parenting books, but it's true. You do have to be strong-willed yourself. And then finally, with any children with any genetic syndrome, or I see this with kids with cancer, sometimes the parents are so sorry about what their children have to go to. They forget that that kid needs you to be just as strict. You know, you're like, oh, you had to go through that MRI procedure today. Here, let's just go to McDonald's and eat whatever you want. You know, it's that McDonald's itself might not be a good place to eat, but most of my patients only like chicken nuggets anyways. So, but what I'm trying to say is just don't forget that you still have to be a serious parent, that just because they have all these struggles doesn't mean that they get a free walk when they get home. Like, oh, you can stay on your iPad all night tonight. Now, there's many, many more. So I didn't bring up those 2 books because I think they're the best. They're just an example of others that here's 2 that I got that are very recent that may be good to use, useful for you to look into. Once again, you want to go through these books, pick out maybe even just go to the chapters of the problems you're having. Say you have trouble with transitions from activities. You might want to go to the transition chapter and see what recommendations they make. All right, a couple, before we finish up, I wanted to say, every year I give this talk, I always go into the literature and look and see what the animal models are teaching me about behavior. So I'm going to feature 3 papers, one that I featured last year, and just tell you what I gleaned from them. So from this paper talking about how the WAC protein, which is involved in DESSH syndrome, it seems to affect a neurotransmitter called GABA. And so I would say this would suggest that GABA dysfunction in neurons leads to hyperglutaminergic, or glutamine or glutamate is a neurotransmitter that's activating, GABA is inhibiting. And this hyperglutamatergic state leads not only to increased risk of seizures, but it also does lead to behavioral issues. The main ones are anxiety and OCD. So just when your child gets trapped in that loop, I've got to do this, I've got to finish this, I've got to do that 3 times, I've got to do that over and over again. For some, it's like you just answered the question and yet they're asking you 4 more times to answer the same question. That's all probably partly due to a hypoglutamatergic state. So it tells me medicine-wise, sometimes we not only have to use these types of medicines that affect this system for seizures, but also for behavior. Here's another one that looked at the WAC gene in different stages of development. And they found that these genes express themselves early on in brain development. So the gene that's involved in DESH syndrome activates early on, maybe at the end of first trimester, second, third trimester, as this young brain is growing. I guess what that tells me is, like my theory with most kids that have behavioral disorders, especially the autism spectrum ones, it's a neurodevelopmental disorder. It's happening the way the brain is developing even before they're born. So the reality of that then is that there probably are not going to be any miracle cures for their behavior anytime soon, because otherwise we would have to go back into the brain as it's developing at that early age and set things right again. Does that make sense? Because it's just like if you're building a car, if you put a piece wrong early on in the building of a car, it's going to affect all the way the pieces fit at the end. So you kind of have to go back. I don't want you to give up hope on that, but it does tell me that it's a very humbling aspect of this disorder and many kids with behavioral disorders. All right, and it also tells me that since some of these areas like the hippocampus is involved in reward and memory, that it is going to be harder to discipline or for your behavioral management techniques to work. Your children will not learn from them as quickly because they don't have the part of their brain that tells them, oh, last time I got in trouble for that, let me not do it again. In fact, do you ever have that? I guess just raise your hand if you had that, where you try something and it actually doesn't stop their behavior. They just keep doing it, even despite having a timeout or taking away something, they still keep doing it. Yeah, that's probably why, because the part of their brain that's designed to make them change their behavior if they're getting a negative result is not as strong. Now, it doesn't mean it's not there, but it means it's not as strong. So it means you have to up the level of the behavior management that you do. And then finally, this, I think, is Dr. Voigt still talking today? Oh, there he is. All right. So I liked your paper and your group's paper. So what I get from this as a child psychiatrist, I'm also MD PhD, so I love geeky papers. It suggests that dysfunction in the GABA would once again lead to that hypoglycemic state. So you kind of agree with that paper last year. And then the memory deficits that you were seeing would suggest that, once again, the behavioral interventions might have limited success. So here's a bunch of animal studies that are, don't have direct correlations to human beings, but help me as a doctor say, what would I target for medicines for these people? And why are behavioral management methods so difficult? All right, so I'm not going to spend too much time on medicine because I think you guys mainly wanted me to focus on the non-medical interventions, but I will be taking questions now and I can take them. These will be in the handouts so you can see what medicines I've used. Here's what I use for some severe aggression. These medicines are heavy hitters though and have lots of side effects, so I'm very cautious with them, but they have been lifesavers in terms of keeping my patients out of the hospital or in school settings instead of being disruptive. Here are ones that I use when anxiety, mood, depression become a problem. They can also be useful medicines for kids that get OCD or have trouble with rigid transitions. All of them have side effects once again. ADHD or impulsivity, we still do try the stimulants. Some of my kids, like on the DESSH syndrome, are also sometimes have side effects on stimulants more often than kids with just straightforward ADHD. So you do have to be careful with these medicines. And then finally, I do use a lot of the anti-seizure medicines I use also for behavior modification, especially if they're having these knockdown, blowout tantrums that last a long time and seem to follow a path of like a partial seizure. Well, there'll be some recognizable thing, that it's coming on, then they'll be kind of glassy-eyed during their blow-up phase. It'll last 10 to 30 minutes. Then they'll come out of it and they'll be either tearful or tired. And then sometimes these medicines get rid of those completely. Sometimes I try them and they don't do anything. So it's not 100%, but Doctors are slowly learning about some of these things. Sleep is usually a trouble for most of my patients. I guess raise your hand if your kid had sleep issues from an early age. All right, so you are seeing a lot of sleep issues. And so here's kind of the routine I go through, making sure you have good sleep hygiene and a bedtime routine. Sometimes these over-the-counter meds or milder meds, clonidines prescription. And then for older children, I'll use some of the stronger medicines for sleep. And then finally, kind of what I've learned, especially from kids on the spectrum, is perhaps you can avoid some medicine sometimes if you stick to some of these parts of life that are important to them. They like things to have structure. They like things to be the same every day, to be predictable, simple, family focus, and consistent discipline. As I always say, this is impossible to do in 2024, but the more you can strive for it, the more your kids will appreciate it. So with that, I'll stop. I think we have 15 minutes for questions. All right, great. Oh, no questions. Great. That's great. Yeah, and you'll have to be comfortable with sharing them in publicly. I'm also going to wait afterwards if you have like a private question.
I was just going to say that if you're not as comfortable talking in front of everyone, last year I had a sidebar and a lot of the things that you said were extremely helpful in going back to my doctors to say, hey, I think we need to try this. I think we need to look at this. And they listened because it wasn't just the parent. There was another clinician behind the scenes giving information and recommendations based on something that our clinicians don't see, don't know about. And I got my autism diagnosis for my son because of you. And we found an excellent cocktail, as I call it, of medications that has really helped to regulate the anxiety and the aggression and the fear in our son. So I commend you because I think you can really help us in finding what works.
Thank you.
There one over here?
Online question, great. Yeah.
This is working. Thank you so much. Our son is quite young. He's 20 months old. I'm wondering, are there things we could be doing now? He's not currently showing anxiety or aggression, just I think because he's so young. Are there things we might do to try and get ahead of what shows up quite a bit in the future? Like, hey, do this now, get him out of the house as consistently as possible so that he's maybe less anxious in the future. Are there any recommendations related to things we might do now to get ahead of things we tend to see?
20 months, so 4 months away from being 2. All right. Well, I would say if you have any of those early worries about, speech or sensory issues, you want to make sure you get them to a speech occupational therapist. I would say the other aspect would be to already start building some amount of structure in your days. Sameness, bedtime routine would be good at this age. Hygiene stuff would be good to set up a, just like a daily routine for everyone. And then, yeah, like you said, making sure you don't use too much screen time, getting him outside and finding what are his kind of like, as they say, is what are his love languages? What are the things that really bring him joy? So you can use those to fight against the anxiety. So just so glad that you're starting early. You probably will avoid a lot of problems that way.
Okay. Hi, thank you. We were wondering if you have a recommended time for the iPad usage per day.
And
And
time per
do
day.
you make a difference between DESSH kids and non-DESSH kids for how long they can use the iPad or should use the iPad?
Oh yeah. Well, I mean, if I go strictly by the American Academy of Pediatrics recommendation, they say no screen time till 2 years of age, which almost seems undoable in this day and age. So, yeah, okay. So above two, I would say, the right answer is the right amount for your kid. So there's no like scientific studies to show what the guideline is. In general, what I would recommend as a psychiatrist, just in experience, would be probably somewhere around 1 to 2 hours a day. That's about the right amount, where in the I guess they call them, what do they call them? Retrospective studies, where they see which of adolescent teens are having behavioral troubles and how much did they spend on their phone. The 1 to 2 hour range is always in a good place with normal levels of, but once you get around 4 to 8 hours, that's when you start to get higher risk of anxiety, depression, lower social skills. Now, I would say if you do have the DESSH syndrome, you probably do need to use your iPad more, or double that maybe, because for them, there's just a lot of enjoyment and sameness in using that iPad. It fills a lot of their needs for repetitive behaviors that you just can't do anywhere else. Like I have those patients that don't watch the whole YouTube, they just watch a little 10-second part over and over again. And and it's very comforting to them. I think if you realize that amount is giving them kind of a relief from anxiety, then that's good. But I would still say you want to keep that as low as you can and try to build in other structures. Hopefully, as we learn more, you guys will teach us what works best for your kids. So.
Someone online said, we've heard that children's brains are very malleable, so their abilities are infinite depending on the stimulus they're subjected to. With DESSH children, it's difficult. Do they have a limit on those abilities they can develop?
All right. So I would say that's kind of a Disney myth, that children's brains are malleable and it's infinite possibility. We all have limitations based on our own genetics, on what our brain can do and how we react to things. In fact, have any of you had that phenomena where as you get older, you start to realize you're acting more and more like your mom or your dad? Yeah, see, there we go. So it just shows us that despite having very different experiences often, our brain's genes affect our behavior more than we ever know. So I think it just, to me, I would agree though with that question, and that children with DESSH probably do have more limitations on how far their brain can go, but there are limits to us all, and it should be both amazing and humbling as a parent to realize that and say, all right, well, let's aim for the best for all of our children, and realize that those limitations are, something that we can't change. We just can make the most of the experiences we do have. So, all right.
Yeah.
Okay.
No more questions? All right. Thank you very much.
One last
there-
question.
good.
All right.
I wanted to get a clarifying statement
Sure.
on a comment that you made earlier regarding DMDD. You said we don't call it bipolar disorder anymore. Was that condition once referred to or treated as bipolar disorder?
Yeah, there was a trend in the late 90s, early 2000s for these kids with very extreme blowups and rapid changes in mood to call them bipolar NOS. And the theory was that it met enough of the criteria of bipolar disorder in adults to warrant it. But then as we did more and more studies, we realized most of these kids do not grow up to have an adult form of bipolar disorder. And therefore, they had to come up with some other term for it. So this one, DMDD, is more of a grab bag than anything useful. It's more like saying, all right, well, this is a really extremely behavioral dysregulated kid, And it's probably a lot more than what we see with ADHD. So let's give them DMDD. So does that make sense? How it
Yeah,
evolved, it's not a logical thing. It's just the way it's evolved historically.
Yeah, so my kid has a grab bag of diagnoses, and that was one that had been given at a point. He was actually treated with lithium
Yeah.
early in his childhood, which showed no positive impact. And to be honest, like all of the medications on your slide, my kid has been on or is on currently to some degree. And I would say the place that we've landed at is mediocre at best.
Yeah.
But, you know, we're kind of painted into a corner because we've tried everything and he's maxed out. His liver can't handle really adding on anything else. We have an amazing psychiatrist. He's considered, you know, adding on naltrexone, but again, metabolized by the liver. We can't really add on anything else. So I don't know. It's just, it's a lot.
Yeah.
And kind of at a loss of where to go from here because he's quite large and strong and aggressive, and this is really the best that we've been, which
Right.
isn't good. So anyway, I just wondered about the bipolar disorder, wondering if perhaps that was an avenue that we should pursue with medication management.
Yeah, so you could try medicines for bipolar, although almost all of them are identical to some of the ones I had on
Yeah.
that list,
Yeah.
as you know. So yeah, since you have a great psychiatrist, I would just keep thinking out of the box and trying new things, understanding that you may not find any.
Yeah.
Just because your child has these diagnoses that have medicines for them doesn't mean they come from the same source as other kids genetically. So that's why your child may not respond to them.
Yeah,
Like,
we just keep trying.
Yeah.
And like with the ADHD medication, nothing has been impactful.
yeah, and truthfully, I have a couple patients like that with other genetic syndromes.
Yeah.
And it's very humbling for both the parents and the doctors because, boy, we want to help, but all I get sometimes is side effects and none of the benefits, and I feel terrible. So, all right, so make sure though you maximize the behavioral things if you can. Yeah. All right, that's about your best route then. All right, well, thanks for your attention, and I'll be around for personalized questions, and I'd be glad to come back again if you ever need me. So thanks.
Thank you so much. So by way of quick introduction, I know many of you are aware that the DESSH Foundation is run by a board of directors, but we also have a medical advisory board, and that's made up of researchers, scientists, and clinicians like Dr. Schnaui. But these researchers and scientists are really studying DESSH in the lab. And so Dr. Vogt has his own lab at Michigan State University, and he's been gracious enough to come here today for us. He is a member of our medical advisory board, so he's constantly informing the research decisions that we decide to make. And he'll also present on behalf of Dr. C.H. Kim, who has a zebrafish model in his country of South Korea. And a little bit later, we'll have Alyssa Erickson speak. She is with the Gable Lab, and Dr. Gable is on our medical advisory board as well. So we're shifting gears a little bit to scientific talk, and I'll kick it off to Dr. Vogt now.
Thank you, Caitlin. Really appreciate your leadership and being a part of this group. And it's good to see familiar faces, good to see new faces. Again, what we do is we're trying to generate a model that we can utilize to understand what the WAC gene does. And both Dr. Kim in South Korea and I have been working on 2 vertebrate models. They are using the zebrafish, which is a really common model to look at various genetic changes, and we're using the mouse model. The reason we wanted to do this is because before we developed these tools, we really didn't have much. We had cell lines that grow forever in a dish, and we had the fruit fly, which is great for genetic studies, but the gene is so different between the fly and the human that we may not do the exact same thing. And so what I want to first do, just to get us back up to speed, I presented some of this last year. And I just want to go through what we have again for our model. So this is what they look like. This is our mice. They look relatively normal. I can say that we've looked extensively in the brain. The great thing about this is it is true. This is a developmental, excuse me, a lot of developmental events are happening in the brain. But the good thing is, at least in our model and the zebrafish model, both of these animals do have all the brain regions intact. So we're hoping that that helps us as we move forward and look into potential therapies. So both of the models that we have, ours is what's called a constitutive heterozygous. All this means is that we knocked out one version of WAC. So we each have 2 copies of it, but we just got rid of 1 copy. And the reason we did this is because a lot of and Dr. Shinawi mentioned this earlier, pathogenic variants kind of outnumber all the other variants. And so this model, by getting rid of 1 copy, mimics those pathogenic variants. In the zebrafish, they did the same thing. Zebrafish are a little weird. They have 2 copies of every gene, so you have to get rid of double the amount. But they actually have created several different ones where they've gotten rid of 1 copy of each or both copies to study what the protein does. So I'm first going to start with craniofacial features that we found in each of our models. I'm happy to say that at least in our mouse model and the zebrafish models, we are able to recapitulate some of the changes in craniofacial structures. If you look up here in the top left, this purple stuff that you see, the purple areas are actually the bone itself. Very early on, what we find is that the frontal F and the parietal, which is a little farther back, have more separation. So the plates in these animals are not fusing like they should. And if we go into the adult on the right here, the frontal areas are actually a little bigger, and some of them don't fuse completely. And Dr. Kim's group actually found in the zebrafish, they also have several changes, like alterations in the jaw, and difference, and also an increase in size in some of these structures. And I do want to say that Dr. Kim's lab has been generous to give us some new data that I don't think we saw last year. But they're now going into understanding what genes might be changed downstream of the WAC gene. And what they've discovered is that there's this gene called ependymon, or EPD. So the purple that you see, that is where the gene is expressed in the craniofacial structures. And in the WAC knockouts that they have, they're losing expression of this gene. So this is one of the biomarkers that we can now look at and maybe manipulate. And they also looked at their zebrafish like we did in the mice. And they're also showing differences in how the plates are fusing together in these 2 models. So we're excited about this because they're showing some consistency between the 2 models, which means that it's likely that the WAC genes in each model are converging in the same pathways. And so relevant behaviors. Each of our labs have been really interested in behaviors that examine learning and memory. That might be something that you'd find in an autism diagnosis like social preference. So what we find in the mice, these 2 diagrams that you see up here, the left one is for our wild type or normal mice that have 2 functional copies of WAC. And on the right, this is the one where we've lost 1 copy. So all the red dots, this is when the mice, when you put them in a cage with either an object or a novel mouse, most of the time, the wild type mice like to check out the new mouse rather than the object. But we're finding that in our WAC cat mice, this doesn't always occur. So they don't seem to have a preference for the other mouse like they do. And in the mouse field, we can't actually ask the mouse how it feels, but this is taken as a social deficit problem in the mice. We also see changes in what is called the Y maze. This is basically, you allow the mouse to explore a maze where it's in the shape of a Y for just a few minutes. And what a normal mouse typically does is try to always find the novel arm because they're really curious. But we're finding that in the WAC mice, we're not exactly seeing that. They have deficits in finding a novel arm, and they'll also go in the same arm over and over again. And then Dr. Kim's group, and I think this is beautiful, actually, they have these, what's called social cohesion. So these fish like to swim in a little school or a group. And what happens is the more they are together and they swim in a group, the tighter it is. So you'll notice that over here in the wild type, that area that you see is really tight. And in the WAC-A knockouts that they have, very diffuse. So they're not actually in the social cohesion group as much as they could. And on the right, this is just a quantification of how far apart they are. So we think that between the craniofacial and the behaviors, we actually do have some recapitulation of the phenotypes. The other thing we've tested are susceptibility to seizures. So I should say these mice do not have overt seizures. You don't just, sometimes when you handle them or you have to put them in a new clean cage, you can trigger a seizure just by stress, but they don't do that. So we wanted to test this and push them a little bit by giving a drug called PTZ. This drug, what it does when you put it, inject it into the animals is it binds to what's called GABA A receptors. It's gonna lower the inhibition and kind of challenge the brain to have a seizure. So we determined an amount that we could give the wild type mice where it would not cause a seizure, but it would cause them to have like pre-seizure type of behaviors. This could be like freezing in a cage or even undergoing like a muscle twitch. And just to give you an idea, we grade these on a scale of like 1 to 8, where 1 is like freezing, really mild. 5 is a typical tonic-clonic seizure where they lose their balance. And 8 is super severe. 8 is where they don't survive, unfortunately, because the drug is too much. And in both female and male mice, we've noticed that this is elevated in the WAC heads. In fact, a lot of them in the sub-threshold dose that we give are having seizures. Something new that we didn't talk about last year is we've also generated models where we can take the WAC gene and knock it out completely in certain cell types of the brain. And the goal of this is to really understand what cell types are doing what behaviors. If we know that, it gives us a much better idea for later therapies. So what we have here is a model where we used what's called Cre-Lox technology. These are basically, I call them molecular scissors, because if we modify the DNA in a certain way and you express this protein called Cre, it will go find that modified DNA and cut it out. So we did this because we cannot generate a full WAC knockout constitutively in every cell. You absolutely need it. And we wanted to understand what cells were involved, like I just mentioned. So what we did is we knocked it out again in GABAergic cells. These are the inhibitory neurons of the brain. They keep everything, balanced. And we also knocked it out in glutamatergic. These are the excitatory neurons. So these two have to work together to get us the balance in our brains. And what we found is that in the WAC conditional hets, so now we've lost 1 copy, but only in these GABAergic cells. We actually have elevated seizures when we target the inhibitory neurons. Again, we divided males and females here. Both of them are having elevated seizures. If we get rid of both copies, it gets much worse. And when we did this in the excitatory cells, and this is actually Dari, who's a grad student here today, did this, we don't see any elevated seizures at all. They're pretty much the same. So what this tells us is that at least for the seizure phenotype, we think it's the inhibitory neurons that are involved. What we're doing now is trying to go ahead and take the same approach and start linking it to behaviors and other phenotypes that are coming up. And so I've already showed you a few new things, but there's other stuff that we're trying to do now to get a better idea of the global, kind of changes in the brain that we see. One of the first things we asked is, what are the regions of the brain that are affected? So we tried to do, cutting sections and looking at things. That was really hard because, as I mentioned earlier, all the structures are there. Everything looks normal, but we know something is a little off. So we talked to a group at UC Irvine that are pretty world renowned for doing small rodent magnetic. I'll say MRI. We all know what that was. But they're really well known for this. Unfortunately, we can't do like little pups. That's too small, but we can do adult animals. So we sent them a lot of our adult animals, and they came back with this. So on the left, this is the whole brain that they measured. And what they found is there is a little bit of elevated volume, especially in the males, but not the females. And I should mention, this is the only thing we've found so far that differs between male and females. The behaviors, everything else I've shown you, it's pretty much similar in both groups. Overall at P30, P30 is what's considered a young adult in these mice. We see a trend towards larger specific brain areas. These charts up here for males on the left, females on the right, these are just showing all the individual sub areas of the brain that they've measured. So we now have this for our cortical volumes, our hippocampal volumes, and our subcortical volumes. We're kind of systematically going through these, trying to figure out, okay, when we do the next study, where do we need to aim? And you brought up the hippocampus. Hippocampus is actually one of the areas that's also changed. Sorry, it's not on this particular slide, but. And then these are just individual examples showing some of the significant differences in different areas. And you will know the female brains actually do have increased size as well, but it doesn't quite match what the males have. So this was exciting to us. And if you want to read about this, there's a paper that's free to anyone on bioRxiv, and I can send you the information for that, we put it up there so anyone could access it while we go through the very long publication process. And so just in summary, so these vertebrate models so far, I think between Dr. Kim and my lab, I think we have, again, consistent phenotypes between the two that match some of the symptoms that some of the DESSH patients have. And again, we're trying to include finding these specific brain areas to go after in more detail, like the hippocampus and some cortical structures. And as I mentioned, we now have mice where you can actually start understanding different cell types, like GABAergic neurons and their role in seizures. And the last thing I want to go on, so this might be super sciencey, but I think it's cool. I want to get back to an important point about genetic variants. If you ever have the chance and you're on the registry or get involved, if you can put the genetic variant that they tell you about when you get the sequencing, this would help us a lot, because we're trying to understand what specific variants might underlie specific symptoms and developmental processes. And just give you an example of why I think this is super important for some of the studies we're doing. What this chart demonstrates is conservation of the WAC gene between multiple species. So the higher this black bar, the more conserved. And what I mean by conserved is when you read the little letters of the amino acid code or the genetic code, if you never change that letter in the species, it means it's really important. If a letter does change, it means that it might be intervening, protein sequence or genetic sequence, but it's not selected to be like, I guess a better way of saying it is, yeah, the more conserved it is, the absolute more important it is. So we go off that principle that you need this certain region of the gene in order for the protein to function. And you can break this down into what type of amino acids in the protein are conserved. So one in particular, you'll notice I have the gene down here where we have the WW domain and the coiled. So I hope you notice that the coiled, that black line up there, it's really high, because that domain is probably really important. Same thing with the WW, that's also really high. What was interesting to us is that there's a part in the middle that's also really high that has these 3 orange bumps. These are a particular amino acid called serine and threonine. I'll show you a picture, but I think I'm already laughing at my picture because I think you'll like it. So, what these are, they're very special because they have what's called a charged group on the side. So every amino acid is like a different puzzle piece or a different toy or a different Lego. And some of them, are neutral. They don't have a charge to them like positive or negative like a battery would have. Some of them have positive residues, negative residues. Serine and threonine are unique because they have what's called an OH group. I don't know if you remember chemistry, if you ever took it, but OH is great because what happens is other proteins can come to that OH and add something to it, like making your puzzle piece supercharged. What happens is that proteins will add what's called a phosphate group to these serines and threonines, and I'll show you what that looks like in the next slide. What we decided to do is look online where a lot of the human genetic variants were falling, and several of them were falling in a group, this highly conserved group that had several of these serines and threonines in them. So what this tells me as a scientist is that there's a group of this protein that could be modulated like an on-off switch. What that does to the protein, we don't know yet, but we're starting to find out. So we wanted to just make the simple test. What if we mutate these individual mutations to a dead version? What that means is you can't add anything to it. It's stuck in place. Or a constitutively active. So we can change it to what would look like the active form of the phosphorylated form of this. And that's exactly what we did. We made these mutations, and then we wanted to test what they did. So this is my phosphate slide. This is exactly what the molecular structure looks like. So that red piece you see sticking out, that's our OH group. When the phosphate gets added, it changes its shape to this thing. Now you have like triple the charge, and this is the switch. And it's kind of like this. So this is what it looks like if you just have the OH group, and then you put Hulk hands on. I'm so proud of this. It literally is something you can put on and take off. And when it's on, the protein changes its function. So we next wanted to ask, so what does that do to the WAC protein? It does something really cool. So I had a really talented undergrad, Luke Schipper, who's been doing what's called Western blots now for a long time. This is a procedure where you can load a mixture of proteins in what's in a gel. And if you give it some electricity to force them to move through the gel, they'll separate by size. So the larger it is, the higher it will be on the gel. The more abundant it is, the darker the band will be. So NT over here means he didn't put this version of WAC in the cell line. And you'll notice on the top, there's no band there. On the bottom, GAPDH, this is just showing that an unrelated protein is not changed. So we want to make sure that when we do this, we load the exact same amount of total protein to all of these, and then ask what changes in the WAC protein. Wild type, this is the unmutated version. You get a nice dark band in the WAC gene. When we make the dead version of this, the protein is a little smaller, which makes sense because it doesn't have all these phosphogroups on it, but it's also way less abundant. When we change this to the constitutively active form, again, you'll notice the shift in size because we now have 7 phosphates on it that make it bigger. But when we do quantification on this, it's actually more abundant as well. So what we think is happening is that this region of the WAC protein, where you have these predicted phosphosites, makes the protein either stable or unstable. And the reason I'm excited about this is this could be one of the ways we can modulate the amount of protein in the cell. So what we're trying to figure out now is what are the kinases that target this domain, and which specific one of those 7 mutations is regulating this. And why this is important for the human variants is this represents 7 patients that are out there. And if we can find the one, we can report it, and then it can be considered a pathogenic mutation rather than a missense. And so with that, I'll go ahead and end here. Just want to thank my lab. I have an amazing lab manager that she is the one that got the mouse here and helped us generate it. Dari, who's working on cell-specific types of effects of the WAC protein. And then Luke is the one who did the Western blot studies. And then also Alyssa, Gil, and Jenna Carr, both wonderful med student undergrad that participated with us. I also want to thank the Chem Lab and recognize very talented graduate student Kanghan Lee, who's helped us with the paper. And then collaborators Juhi Zhang and Andy Albanese, they did the craniofacial work on mice and the MRI work, respectively. And then thank you to everyone who gave us money, because we couldn't do it without you. But And with that, I'd be happy to take any questions, anything you want to know.
I'm just reminding you to mention the P53, please.
Yes, there was a Zoom question that came on, or one of the, so the question was, have we looked at the protein P53? We haven't yet, but it's something we could do very easily. P53 is like a DNA checkpoint. If the DNA is damaged, it tells the cell don't divide. So if it is changed, we could look into its link and potentially growth or no growth in some of the cells.
Okay. I'm wondering if you had infinite resources, dollars, grad students, and time was compressed, where do you see this going? What do you hope are the next big steps? But think not just like next year in reality, but like if you had more resources.
That's a great question. Thank you. So I'll tell you what I write in every grant. And what we really want to do, and this is actually starting, I think. Can I talk about the stem cell? Okay, I won't talk about it. No. Oh, geez. Oh, you want me to? I just was like, don't tell him. This is a collaboration between Harrison Gables Group, the Stem Cell Core at St. Louis, WashU, or in St. Louis. And the big dream right now is part of it is screening more variants. I think if we can get more variants screened, especially the missense ones, it will help people. So I've been told that once that gets published or gets put on a registry and is called pathogenic, then it really helps with moving forward. But the big one that I'm very excited about, and I think all of us are going to work on this, is we're trying to create the human stem cells to differentiate into neurons. And this is at the guidance of Dr. Shinawi. He's going to find a good representation, good mutations that we can look at. Stem cell technology has come along enough now to where we can differentiate them into neurons and start studying them in vitro. And the ultimate goal is once you have the human cell lines and you can show that you have changes due to the mutation, we can attempt to genetically rescue it with a wild type human version. Once that step is done, then you can start it's a long road, but the next step would be trying to see if putting the gene back could either prevent or help some of the features of DESSH. It also helps us because we can take this and learn what is going to be conserved in the human condition based on the animal models that we have right now.
I'm just going to add there. I mean, one of the things that we're so excited about is that as a foundation, we are able to fund now creating cell lines, which we did not have before. They were not available to researchers. They live forever. And so they're available to lots of researchers. And so I think that's what Dr. Vogt's talking about is with our medical advisory board's help and Dr. Gable's help, we're moving forward with taking some of the biopsied material that we have and developing cell lines, which should be available in a year or so for researchers to work on. And that opens a lot of doors.
Yeah. And once they are generated, you can propagate them and store them just like sourdough bread. Literally, because of that, we can share them with a lot of groups that want to do it. They're going to make them here. And then once they make them, they're going to ship me some, and hopefully other groups will take this on. It's a great question though, because that's our dream. That's where we're trying to go with it.
Hi, since you just mentioned this, the skin biopsies, we're newbies here. This is our first year at the clinic. So I noticed on the original schedule we got that only some patients were asked to do skin biopsies. Why is that? Have others done it in previous years or just, okay. Okay. I was just curious, not really a big deal. I was just thought. What?
Okay.
She just wants to know why not everyone got skin biopsies.
Oh, okay. So here, can you hear me? Yeah. So there are different considerations. One of them, we selected certain mutations. Some of these are recurrent mutations. Second consideration, the cost. So to do this process, this is really thousands of dollars. So we decided just to choose certain mutations that are more representative. But this can be, in the future, if this is really very successful, ultimately we need to do for everyone. So if you're coming next year, definitely this can be a consideration.
Thank you.
So we referenced the Gable Lab a few times. This is Alyssa Erickson. She works at the Gable Lab here at WashU, and she's going to go through some of the work that they've been doing as well.
Thank you so much. Thanks for the introduction. So my name is Alyssa Erickson. I'm a graduate student in Harrison Gable's lab. He wasn't able to make it today, unfortunately, but so I'm going to here on his behalf to give you kind of an update or a kind of overall summary of our work in the lab focused on understanding the WAC gene. So I've been in Harrison's lab for, gosh, almost over 2 years now. And so I'm kind of going to go through some of my work in the lab under this focus. So I know we're a little short on time, so I apologize if I speed through certain parts a little bit more, but you should be able to get my email. Definitely, I don't know if it's on here, but I know Caitlin has it. So if you have any questions, like clarifying questions, please feel free to reach out to me and I'm happy to talk about anything more. So just some quick background on our lab overall. So we're here at WashU in St. Louis in the medical school, and we're in the Department of Neuroscience, and Harrison's lab has been around for almost 10 years now, since 2015, with the goal of kind of understanding how genes are turned on and off during brain development and throughout brain function. And to do so, we really focus on the core molecular roles of certain genes, so what they're doing in your cells, particularly in the neurons of the brain, that primary cell type in the brain. And then we like to take what we can learn from studying these genes and apply that to a better understanding of the neurodevelopmental disorders that might be associated with those genes. And in doing so, we've had really the incredibly lucky opportunity to be involved with a number of really wonderful patient advocacy organizations over the years, such as Tatten-Brown-Raman syndrome community, Rett Syndrome Foundation, and more recently, all of the wonderful people at the DESSH Foundation. So some quick biology background of what it is that we do is we focus on understanding what genes do, what certain particular genes do in cells. So what genes are, they're units of your DNA that encode for proteins. And proteins are basically the functional machinery of your cells, that they each have, every gene codes for a protein that has a unique function, that they all work in concert to do things that your cells need to do, like divide or respond to an environmental stimulus. And one of these functions is some proteins decide whether or not other genes are turned on and off. So some proteins, it's their function to regulate the protein production of other genes. And this is important because you have the same genes across all cells in your body, but all of your cells are different because they express different genes. So we need these proteins to be able to correctly turn the right genes on or off in the right times in development and in response to things you just go through in your daily life. And this is important because we think that WAC is one of these genes, that its protein product is responsible for regulating whether other genes are turned on or off. And the way that this happens is through something called histone modifications. And so Dr. Vogt set this up really well when he's talking about phosphorylation as a change to a certain protein. This is very similar, where you can introduce changes to something called histone proteins. And histone proteins are, to back up for a second, you have almost 6 feet of DNA in every cell, and that needs to be compacted really tightly into the nucleus in a manner that doesn't look like throwing a ball of yarn in a purse, which I've been the unfortunate recipient of trying to be on the other end of that, and that makes it really hard to organize your DNA if it's like that. So instead, it needs to be very neatly wrapped around these histone proteins so that it can be nicely compact in your cell, easy to access, easy to utilize, so that these proteins can be made correctly. And these histone proteins can be modified. So modifications can be added onto them so that they can make the DNA more or less accessible. And what I mean by that is that when I say your DNA is wrapped around these histones, that means all of your genes that need to make proteins are wrapped around these histones as well. But the machinery that needs to make those proteins needs to be able to access the genes. And so some histone modifications, such as the green one here on your left, they might make the DNA a lot more accessible. So it kind of unwinds a little bit from the histone proteins, and you can produce proteins a lot more easily. That would essentially turn the gene on. But then some histone modifications, like the red one here, might cause the DNA to be a lot more compact on the histones, and that's essentially turning the gene off. And WAC comes in here as an adapter protein. So if you remember, the name of the WAC gene is WW containing adapter with coiled coil. What that means is that WAC functions to bind different proteins within a cell. And what it does is there's some evidence in some other systems that it might act as an adapter between a protein called RNA polymerase, shown here as RNAP. And that protein is found at genes. And then it also binds a complex that we call RNF20, RNF40. And what to take away from this is that WAC brings RNF2040 there to deposit a histone modification. So WAC is necessary for that histone to be modified. And the histone modification is what we call histone H2B monoubiquitin. For short, I'm just going to say H2B ubiquitin because it's kind of a mouthful. So what's happening is a histone called H2B gets a modification that's called monoubiquitin. And there have been some studies in different systems that suggest that WAC is necessary for this process by being an adapter, as shown here. Now, the interesting thing about H2B ubiquitin, I described before that some modifications turn genes on, some turn them off. H2B ubiquitin seems to be a little bit more nuanced, where when you get H2B ubiquitin at a gene, sometimes in certain cell types, that might turn that gene on, but in a totally different cell type, having H2B ubiquitin there, it might turn it off. And this is important because WAC has really, when I started this project, WAC had only been studied in this role of H2B ubiquitin in yeast and some cancer cell lines, which when we want to think about what is WAC doing in the context of the brain for the context of DESSH syndrome, knowing what it does in yeast is helpful. It's a starting point, but it doesn't really give us that jump that we need to understand what it's doing in the brain. And so my question has really been, okay, so what exactly is WAC doing to impact this H2B ubiquitin pathway and resulting gene regulation by this H2B ubiquitin mark? What is it doing in neurons, the primary cell type of the brain, where we see a lot of the characteristics of DESSH likely can come from dysfunction in the brain. So it's really important to understand what exactly WAC's role is in the brain. And so to approach this question, Dr. Boat kind of alluded to this as well. It was kind of why we actually go sometimes on the research side to generating complete knockouts of a certain gene. Even though in the DESSH context, we do typically just see a 50% loss of the WAC protein. We're starting with here a complete WAC knockout and asking what it does to H2B ubiquitin, that histone modification and resulting neuronal gene expression. And so we use this complete knockout first because this really allows us to determine the core functions of WAC. So from a research standpoint, to define what, as a protein, what is WAC doing? And from there, that allows us to make discoveries a lot more easily. We can confidently say, okay, we see it's doing this function. And then the overall goal is to bring those findings back to the disorder model, look in the heterozygous WAC knockout, so that 50% loss, and say, okay, now that we know where to look, is WAC still doing the same thing? And so the way that we make this entire deletion of WAC, I won't go through the details here right now just for time, but essentially what we have a mouse model that's very similar to what Dr. Vogt described, except that the copies of the gene aren't actually deleted yet. We can wait to actually make that deletion until we introduce expression of a certain protein called Cre recombinase. So what you need to know for this mouse model is that whenever the cells of this mouse are exposed to Cre recombinase, that completely removes the expression of the WAC protein. And so we use this, the way that we use this mouse model is we actually take the embryonic cortex, so when the neurons are still very young, and then we can plate them, we can break apart those neurons and plate them in a dish. So we allow those neurons to grow and become mature neurons, in a culture context, which makes them very, very manipulatable. So we can, get rid of the expression of whack. Potentially, we could introduce new versions of whack, like maybe some of the mutants or something that Dr. Vogt described, and see what happens in those neurons. So this system, we can ask questions a lot faster and get very robust results. And so in order to get rid of whack, we have these cultured neurons, and we express that recombinase protein. And what that gives us are neurons that have a knockout of whack. So I'm going to call this whack knockout, so complete loss of the whack protein, and then just control neurons that express a typical amount of whack. So now we can ask how H2B ubiquitin is being affected in neurons that lose whack. So Dr. Vogt already kind of described this as well. So this is, again, now you're looking at a Western blot where we can quantify the amount of certain proteins. And so we first validated that we can actually get a complete loss of whack in this system. So you can see in the, in this top row right here, this is the amount of whack protein in our control neurons and the amount in our whack knockout neurons. And this is just demonstrating we have the same amount of protein in both samples. So you can see a very significant loss of whack in that top row there. So we did successfully generate a whack knockout. And then when we ask whether H2B ubiquitin is affected, we can similarly use that same Western blot technique to quantify the amount of this histone modification. So histone H3 here on the bottom is telling us that we have the same amount of histone protein, but that modification H2B ubiquitin is drastically decreased in the whack knockout. And so this does implicate whack in the H2B ubiquitin deposition pathway, specifically in neurons. So the question then is, okay, well, we see this loss of H2B ubiquitin. That's really exciting. That means this pathway is something we could think about for therapeutic targeting. Think about how, like, if we could rescue H2B ubiquitin levels, is that something that could have a therapeutic benefit? Is something we could see in the mice or in the neurons. But going from there, we still want to understand how is that loss of H2B ubiquitin actually affecting how the neurons are functioning. And in this context, one thing that I kind of thought of right away is, well, H2B ubiquitin is involved in gene regulation, turning genes on or off. And one time for neurons, a particular time when this is really important for neurons, is something called activity-dependent gene expression. And so what this is when a neuron receives a stimulus, so all the neurons in your brain are getting signals from other neurons. They get those signals, they need to send a signal to the next neuron. When they get a ton of those signals, they're considered to be activated. So those neurons get activated, and there's a set of genes that need to make proteins really rapidly in response to that activation. And those proteins that they make really quickly to respond, they're absolutely necessary for things like synaptogenesis, so that's making new synapses during development, modulating existing synapses, so those connections between neurons, and all of those protein products, they're necessary for forming those circuits that your brain needs to make during development, and then staying plastic and malleable throughout any organism's lifetime. And so importantly, in other systems that have really rapid gene expression responses, so non-neuronal systems, H2B ubiquitin has been shown to be necessary for those gene expression programs of those response genes to respond correctly. They either get, they respond too much or they respond too little when you lose H2B ubiquitin. So our question is then, is this whack-mediated H2B ubiquitin that we see happening in neurons, is that necessary then for neurons to respond to synaptic activity properly by expressing these genes? So we can use basically the same system. We have our neuronal culture, and like I said before, this allows it to be very manipulatable. So what we can do is we can generate those whack knockout and control neurons, and then on the end of the diagram here, we have adding potassium chloride. And what this does is we add potassium chloride to our neurons in the dish, and that activates them. So that compound causes a rapid depolarization and activation of all the neurons. And then I can study the time points after that and ask, when we lose whack, do we get the correct gene expression response in response to being activated? And so what I'm showing here is just looking at the control neurons first, and these are two example genes that get activated very rapidly in response to neuronal activation. And so on the x-axis here, I have, this is just hours after that neuronal activation, so time after activating the neurons. And then the y-axis is just how much those genes are being expressed, so how much protein they're producing. And you can see from just that no activation at 0 hours to 1 hour, they get induced very rapidly, but they also start to then turn off again at the later time points. And this is because it's not only important for neurons to correctly respond to signals, but then they have to go back to a resting state so that they're ready to respond again. And now when we lose WAC, what we actually see is that these genes are induced correctly, but they're not turned back off correctly. So it suggests that WAC is playing some role in making sure that those neurons turn those genes back off and they're ready to respond to new signals. So they respond, they over-respond when WAC isn't present. And because we're interested in really defining what's going on at the molecular level in this context, we've already seen that there's a loss of H2B ubiquitin in these neurons when WAC is missing. So is H2B ubiquitin is it really driving this effect that we're seeing here? And so to ask this, we use something that's called chip sequencing. And so that's a genomic assay that essentially lets us measure how much of a given histone modification is at every gene in your DNA. So what I'm showing here is some example data from this chip sequencing, where the kind of blue rectangles along the top, that's just representing one of those, the structure of one of those response genes. So that's the length of a response gene, the same gene that I'm showing there on the left. And then the height of those gray tracks for every time point after activation, the height of the tracks represents how much H2B ubiquitin is there. So at 0 hours, there's no H2B ubiquitin and almost no protein production of this response gene. But then after those neurons get activated at 1 and 6 hours, there's this really rapid buildup of H2B ubiquitin. And that tells us that H2B ubiquitin, mediated by WAC being present, is likely playing a role in turning these genes back off again. And when we lose WAC, we do see that at the level of looking at these specific genes, we don't see that same buildup in H2B ubiquitin, suggesting that it's this loss of H2B ubiquitin that might be driving the deficit in proper gene expression response. So just to, okay, so this is just a quick summary that in both conditions, we don't see any H2B ubiquitin buildup and we don't have expression of these proteins. And in the control condition, when they get activated, you see this buildup of H2B ubiquitin, but no protein, a normal amount of protein production. In the WAC knockout condition, in response to neuronal activity, you get overproduction of these response genes. And this can be an issue in circuit function and formation. Like I mentioned before, neurons need to be ready to be activated again. If they can't come back down to that kind of baseline readiness state, they're not going to be able to properly receive and send signals. And this has been, consequences of this have been observed at the level of even behavior, kind of like what Dr. Vogt was talking about, where there's some learning and memory possible deficits in these spontaneous alternations in the Y maze. There's been a lot of work that has shown that this gene expression pathway, disruptions in it can cause learning and memory differences. So this could be kind of a molecular driver of some of the behaviors that we see kind of disrupted in DESSH patients. And so I apologize, I'm running a little low on time. So my next question is to move this into the model. That's the exact same model that Dr. Vogt just introduced. So I'm going to go through this part just a little bit faster because our question is, okay, great, we saw this in the neurons with a complete knockout, but do we see the same thing in the heterozygous model that's most closely recapitulates or mimics the disruptions that DESSH patients see? So we do see the same loss of H2B ubiquitin. And I just will mention that in a different part of the brain region than we studied, Dr. Vogt did not see the same change in H2B ubiquitin. So it's possible that has a different role in different cell types or brain regions. So that's kind of along the same line of what Dr. Vogt mentioned before of we really want to understand what WAC's doing in every different cell type and region of the brain. And so I'm going to skip this part for now because it's not data, it's just kind of future directions. I want to basically do some more behavioral tasks to assess, does a disruption, this H2B ubiquitin in the WAC mouse model, does it lead to really robustly, I'm going to do some robust measurements to determine whether that's affecting behavior like learning and memory and to what extent. So some overall conclusions from what we've been working on the past years. So we've established this system, this culture system, where we can study a complete neuronal knockout of WAC. And this helps us to really better define its core function. And then using that model, we showed that WAC regulates global H2B ubiquitin levels in neurons, and then also in the whole cortex in that DESSH mouse model, the heterozygous loss of WAC. And then the consequence of that H2B ubiquitin loss seems to be, or one of the consequences anyway, is that you lose the proper regulation of this activity-dependent gene expression, particularly in that silencing the genes following activation. And like I mentioned, this is really exciting because getting a better idea of the H2B ubiquitin pathway and its disruptions in DESH really opens up kind of the umbrella of therapies we consider, because we talk about gene therapy a lot, and that's typically thought of as just putting back the gene. So if we can replace the levels of WAC, is that enough? But if it disrupts other pathways, we can think about, okay, well, can we just target that pathway specifically, kind of get around WAC and ask, well, what if we just rescue the levels of H2B ubiquitin? Is that something that could have a therapeutic benefit? And so this is something that we're thinking about. So overall, yeah, future directions are getting a better molecular understanding of how that H2B ubiquitin loss is really driving this activity-dependent gene expression effect. And then does this loss in the mouse model, does that lead to changes in learning and memory very robustly, with the overall goal of really being able to bring that molecular change of a loss of H2B ubiquitin all the way up to the behavioral level and make those connections so that we can better understand what we could possibly target for therapies. And so I just want to thank everybody in the Gable lab, particularly Harrison. It's been a wonderful mentor, and everybody else in the lab has been so supportive these last couple of years of research. Huge thank you to Dr. Amanda Smith, who provided this mouse model for us. And of course, Dr. Shinawi, who's been an invaluable source of expertise. And huge thank you overall to the DESSH Foundation, to all of you guys being here. It's incredibly important, and it's very, very beneficial for us as researchers as well. So thank you very much. Time for any questions?
Questions?
Yep.
Thank you. So one of the things I saw there was, and I don't know the mechanics of it, the Cree recombinase you use to knock out WAC. Is that something that can simply be inverted in its function? Or that's only to knock out, I guess, the homozygous, you're knocking the whole thing out, it's a pretty blunt object. And for like a heterozygote scenario, it wouldn't be specific enough? I don't know if there's any detail.
No, that is a wonderful question. And so I did kind of skip through the descriptions of this a bit. So unfortunately, it can't necessarily be reversed in the way that I could be used as some kind of therapy to increase the expression levels, if that's kind of what you're thinking about. It's great line of thought. Unfortunately, it's the way that we have this mouse model designed. What Cree recombinase does, if you see those little like yellow triangles that I put there, we've introduced specific gene sequences represented by those triangles into a mouse, where when those sequences are present, the Cree recombinase is able to take those sequences and it just deletes what's in between. So we can use that to conditionally remove the gene, but unfortunately, using Cree recombinase in a model where there is no sequences it can act on already, it doesn't have any kind of effect. And all it does is remove regions, so it can't necessarily like increase expression or anything.
Got it. Thank you.
Okay. Oh, I think there was one question.
Does it really matter if you have the same copy or different copy of the gene with the pathogenic variant in one of the copies?
I'm sorry, when you say the same copy of the gene?
I keep hearing the word heterozygous pathogenic variant. Does the heterozygous have any importance for this condition, severity or mildness?
Yeah, so just what is the relevance of the heterozygous when we say that to the DESSH variants?
Yes,
essentially? Yeah, that's a great question. So when we say heterozygous, what we're doing in these mouse models is that it's essentially like what I described right here. A while back, we essentially used recombinase to generate a deletion in just one of the copies of the WAC gene. So one of the copies of the gene just is not producing any protein, so you just get 50% of the WAC protein. And the reason that we use this model is because the majority of the variants that have been identified in DESSH are predicted to be loss of function. And so what that means is that it's a variant that that amino acid change, or sorry, that DNA change leads to, on that copy of WAC, no protein is produced. Likely, that's what we predict. And so by just getting rid of one copy, we think that that's representing what's going on in a majority of DESSH patients. And so when we say pathogenic variant, that just means that it's something disruptive in the gene. And in DESSH, the majority of time, that disruptive thing is likely just leading to no protein production from one of the copies. And so that essentially mimics what we think is going on most of the time in patients. Does that make sense, or did that answer your question? I could talk to you later too as well.
Last question.
Hi, I have a challenge for you. There are lots of people in this audience who are not very scientifically inclined, yes? Could you explain how WAC is affecting our DASH patients in a very simple analogy, maybe? I know that's a lot to ask. Thank you.
Yeah. So essentially what I'm seeing here, I feel like I had a good one earlier and then I maybe forgot it. But I guess with any loss of a protein, I don't have a good analogy. Someone in my lab that just makes the best analogies, and I'll have to like get her to do one and get back to you. Sorry? The yarn. Oh, yeah. Yeah, so what's important about the histone modification that WAC likely, the change in your cells, that when you lose WAC, what's happening instead is that likely your DNA is not producing the right proteins and at the right times. And so that's really important for all your cells to do their jobs. And if you think about, any other cell type, say your cell, when you're developing, a cell has to know that it needs to divide, and genes turn on to tell it that it needs to divide. When WAC is gone, those signals maybe aren't quite right. And that might be due to something that's going wrong on how the DNA is regulated. So WAC might be telling some genes to turn on sometimes, some genes to turn off different times, and that gets a little bit disrupted when WAC isn't there. I'll have to find a better analogy.
Thank you. I think part of that too is the work that they're all trying to do is to continue to characterize how this disease works and how it manifests in us. They're comparing models and hoping to find the same expression in humans to be able to manipulate and figure out treatments. Thank you, Alyssa.
Absolutely. Yeah. Thank you guys so much.
Okay, so I had a few slides, but I am just going to share them with you online because we're about 10 minutes away from babysitters needing to go and kids are probably getting out of hand or need a break at least. But I do just want to point out a couple of things that I was going to mention. This group was organized because if we, the patients, don't do something, it won't get done. We're the impetus behind so much of everything that these doctors and scientists and researchers are doing. And so a lot of folks come to me and say, well, what can I do? And in that moment, I really don't always have an answer because there isn't a project that I need something hands-on for. But I will tell you something that would be beneficial always across the board. Follow us and like us on our social medias, reshare everything that you see us post. You are our network. And you don't have to put your face or your child's face behind anything that we do. But it would be wonderful if you showed the support because, 10 people and 10 people and 10 people and they know 10 people and they know 10 people. And it takes an awful lot of resources and funding to make what you see here happen and all of the work that we really want to do down the line happen, including with the new human stem cells that we are putting into production for continued research. So the number one thing you can share right now is the Dash for DESSH, which is coming up. It's a week long that we allow people to do enter time for a virtual run. It's an easy sign up. It's dashfordesh.com and there's flyers over here. You can take those, pass them out. You can share them with your social media friends online there was another thing. The patient registry that we have going is really another important means of data collection that comes direct from you. It does not have to be collected from a doctor. You do not have to come to St. Louis to provide us with information on your DESH patient. So RareX is the patient registry. It's a series of surveys that you can fill out online at your leisure, and links are there on DESSH.org for that. So this concludes our week-long, 3-day-long journey together. I'm really, really happy again to have seen everybody here. And I hope we can memorialize this with a photo. I think it makes the most sense to do it maybe right here if we can grab our children and run back down. If anyone does not have to rush to the airport just yet, it would be wonderful to get everybody in a big photo right here after you get your kids. See you then.